We are talking about autonomic pharmacology, and it's just, well, it's the absolute foundation for massive fields in medicine.
It truly is. I mean, most of us just take for granted that our heart beats, 100,000 times a day?
Wow.
Or that our pupils adjust to light, that you can digest a meal while, simultaneously responding to some kind of stressor. All of that regulation is handled by this involuntary system.
Okay.
So today, we're undertaking a really structured deep dive. We're going to move step by step, slide by slide, from the big picture, the nervous system architecture, all the way down to a single crucial molecule, acetylcholine, and the specific locks it opens.
And our mission for you, the learner, is to provide a definitive, jargon-free understanding of this whole system. We're going to unpack every single concept found in our source material, using analogies and mnemonics to make these complex, crucial mechanisms stick.
Immediately.
If you leave this conversation feeling completely fluent in the language of the body's autopilot, well, then we've done our job.
Ready to dive into the wiring.
Let's do it. Okay, so let's unpack this and start mapping the command structure. Now, coming to our next slide, we can really see the big picture.
Right.
We begin with the absolute, the whole thing, the entire nervous system. You have to think of it as the ultimate communication network that governs every single action, feeling, and physiological process in your body.
Yeah, everything.
And it has two essential pillars, forming this division between, say, the processor and the wires themselves.
Exactly. The first pillar is the central nervous system, or CNS.
The CNS.
We call this the brain trust. It's the core processor, and it's housed safely inside bone, the brain, and the spinal cord. Its function is really high level. It takes in sensory information, processes it, makes decisions, and then it issues the command. It's like the server room for the entire operation.
And then you have everything else, all the extension cords, basically, that connect that server room to every corner of the body.
And that's the peripheral nervous system, the PNS.
The PNS.
This is the communication network, this vast network of nerves that branch out from the CNS, acting as the critical wires connecting that core to all the muscles, organs, and glands.
Okay, so within that PNS, that's where we find the first crucial split, right? This is where we divide the conscious from the involuntary.
That's it. The flowchart shows us the somatic nervous system and then the autonomic nervous system, or ANS. And this is that essential dichotomy we mentioned a second ago, the driver versus the autopilot.
And we're really setting the stage right here. The rest of this deep dive is going to focus entirely on the ANS.
All on the autopilot.
All on the autopilot, the part of you that keeps the lights on, regulates the temperature, and, monitors the security cameras without you ever having to press a button.
So let's move from that big picture split. And if we look at the next slide, we can see how the conscious driver is wired differently from the automatic pilot.
Yeah, the third slide really defines this mechanical difference between those two branches. On one hand, you've got somatic control. That's the voluntary side.
The conscious driver.
The conscious driver. If you decide right now to, tap your foot or lift your arm, that's the somatic system firing.
And if you look at the mechanism, it's just beautifully simple, which reflects its direct purpose. If you decide to move, the signal flows through a single motor neuron.
Just one.
Just one. It connects the CNS directly to the skeletal muscle. It's a direct, unfiltered line. Point A, the spinal cord, to point B, the muscle. Simple.
So its function is immediate voluntary movement.
And maintaining skeletal muscle tone, yeah.
Now, contrast that direct line with the autonomic or involuntary control. This is our automatic pilot. So if the somatic system is about immediate action, the ANS is all about regulation. It works tirelessly in the background to maintain what's called homeostasis.
Which is just the body's constant state of internal balance.
Right.
And because it controls these incredibly complex critical systems, circulation, digestion, glands, breathing, it just can't rely on a simple direct line. It needs a checkpoint, a regulator.
Okay, so what does that look like?
This means the ANS uses a two-neuron chain. A preganglionic neuron leaves the CNS, but before it can get to the target organ, it synapses or connects with a structure called a ganglion.
Ah, the ganglion. That's the relay station.
That's the relay station. From that ganglion, a second neuron, the postganglionic neuron, then carries the signal the rest of the way to the effector cell, which might be the smooth muscle in your gut or the pacemaker cells in your heart.
So why the extra step? Why a two-neuron chain instead of the simple, one-and-done neuron in the somatic system?
That's the key question. It's because the ganglion provides a point of regulation, of integration, and even amplification. Signals coming into the ganglion can be modified, they can be amplified, or they can be restricted before they ever hit the final organ.
It's like a supervisor.
A supervisor is the perfect analogy. This added layer is absolutely essential for the fine-tuned control you need to maintain homeostasis without your conscious awareness. You don't decide to sweat or to raise your blood pressure. The autopilot makes that calculation through this complex relay system.
That makes perfect sense. The systems that keep us alive need a supervisor, and that supervisor is the ganglion. Okay, so let's look at how the autopilot decides what commands to issue, because it actually has, two very distinct personalities.
Right, and now, coming to the next slide, we can break the autonomic nervous system into its two functional components. They are constantly in this dynamic opposition, maintaining that balance we call homeostasis.
On one side, we have the sympathetic system. This is the one we inherently associate with action, with intensity, and stress.
We call it Mr. Go.
Mr. Go. I like that. Its motto is the famous fight-or-flight response.
Yeah. And Mr. Go's function is to prepare the body for immediate, intense survival. It triggers this massive mobilization of resources.
So what does that mean in practice?
It means diverting blood flow away from, say, your gut and towards your skeletal muscles. It raises your blood glucose for quick energy, and it increases your heart rate and your lung capacity. It's that surge of adrenaline you get when you step unexpectedly into traffic.
Or have to give a speech.
Or have to give a speech, exactly. It sacrifices long-term maintenance for immediate survival.
And balancing that intensity is the parasympathetic system. This is the system that's all about recovery and maintenance.
We call him Mr. Chill.
Mr. Chill. His motto is rest and digest.
And that's exactly what it does. Mr. Chill handles all the calm, routine, housekeeping functions.
Housekeeping.
Maintenance, energy conservation, nutrient processing, waste elimination. It's the dominant system when you're relaxed, reading a book, or, crucially, when you're sleeping. It brings the heart rate down, constricts the pupils, and ramps up the digestive tract.
And the key insight here, the one that really must stick with you, the learner, is that these systems are not like light switches. They're not just on or off.
No, not at all. Think of it like an accelerator pedal and a brake pedal in a car being pressed at the same time.
Okay.
You're not operating in a purely sympathetic state or a purely parasympathetic state. They're both always active, and the body fine-tunes the output by slightly increasing the input from one while decreasing the input from the other.
So it's this constant wrestling match.
That wrestling match is homeostasis in action. And since they have such different functions, it makes sense that they are wired completely differently.
Which is what we see if we're coming to the next slide.
Yes.
Let's look at the anatomical architecture that supports these roles.
Yes. Segment 5 is the physical wiring diagram. And this anatomy is so crucial because it dictates how drugs can selectively target one system over the other.
Okay, so let's start with the sympathetic system. Where is it located?
Its location is highly concentrated. We say it has a thoracolumbar outflow.
Thoracolumbar.
Meaning the nerves emerge exclusively from the thoracic, that's T1, the chest and the lumbar, L3, the lower back regions of the spinal cord, so T1 through L3.
So it's right there in the middle of the torso.
Which gives it easy access to all the core trunk organs. Now, the parasympathetic system is located at the anatomical extremes.
So not in the middle.
Not in the middle. It has a craniosacral outflow. The nerves emerge from the brainstem through the cranial nerves, especially the vagus nerve, which is a huge one, covering the heart and the gut, and from the sacral region, S2, S3, S4, at the very bottom of the spinal cord.
Controlling the pelvic organs.
Exactly. So little analogy for learners. Sympathetic is in the middle, T1 to L3. Parasympathetic is at the ends, the head and the tail.
And that difference in origin already hints at their function.
Yeah.
But now for the structural difference, which explains the speed and the focus.
Right. Look at the sympathetic structure. It's designed for widespread, quick action, like an emergency broadcast. The first neuron, the preganglionic fiber, is short.
Very short.
It connects almost immediately to the ganglion, which sits very close to the spinal cord. And crucially, once the signal hits that nearby ganglion, the second neuron, the postganglionic fiber, is long.
Okay, so short then long.
Short then long. And here's the key point. A single preganglionic neuron often connects to multiple postganglionic neurons in multiple ganglia.
So it branches out.
It branches out, allowing the signal to spread widely, triggering a simultaneous body-wide response. One short signal out, and then a massive branching long-distance signal to multiple organs at once. That's the anatomical basis of the mass discharge that defines fight or flight.
In sharp contrast, the parasympathetic structure is all about precision.
Precise, targeted control. It uses a long preganglionic fiber that travels nearly all the way to the target organ. The ganglion is located right next to, or sometimes even inside, the wall of the effector cell.
Which means the second fiber must be tiny.
Exactly. The postganglionic fiber is very short. Think of this as a personalized email, not a broadcast. The signal travels discreetly for a long distance before it hits its one targeted relay point right at the destination.
Which ensures that a signal meant to slow your heart doesn't also, trigger a response in your colon.
Precisely. This difference, long pre-short post for precision versus short pre-long post for diffuse action, is the first critical structural distinction you have to master to understand how drugs can be targeted.
Okay, we know the wiring. Let's see what happens at the end of the line. Now, coming to the next slide, how do our organs actually respond to this antagonistic input?
Well, segment 6 gives us the tangible results of this dual system, focusing on what we call dual control. Most of your organs are innervated by both sympathetic and parasympathetic systems, and they have opposite effects.
Let's start with the central player, the heart. When Mr. Go, the sympathetic system, takes over, what happens?
We see a dramatic increase in heart rate and the force of contraction. You need blood pumped hard and fast to feed your muscles for running or fighting.
And then Mr. Chill, the parasympathetic system, slams on the brakes.
Complete opposite. It causes a decrease in both heart rate and force. When you're resting, you need to conserve energy and have slow, efficient circulation.
Okay, what about the eyes? The pupils?
Sympathetic stimulation causes dilation, which we call mydriasis.
Mydriasis.
When you're stressed or in the dark, your pupils open wide to gather the maximum amount of visual information about your environment. A little trick is the D for dilation and the D sound in mydriasis.
And the opposite.
Conversely, parasympathetic stimulation causes constriction or meiosis. This happens when you relax or you're focusing on a near object. It limits light entry and improves your depth of focus.
Makes sense. Okay, moving to the lungs. The bronchi.
For fight or flight, you need maximum airflow. The sympathetic system causes relaxation, or bronchodilation. It opens the airways.
And this is why so many asthma drugs are designed to mimic that sympathetic pathway, right? To force those bronchi open.
That's exactly it. On the flip side, the parasympathetic system causes constriction or bronchospasm. And this is what can become an overactive response in diseases like asthma, where Mr. Chill is constricting the airways when it shouldn't be.
Finally, the gut. The motility and sphincters. This one's the clearest illustration of the competing mottos.
For sure. When the sympathetic system is dominant, it causes a dramatic decrease in motility and an increase in sphincter tone. Everything just slows down, and everything is held in. Digestion is a very low priority task when you're in danger.
Whereas the parasympathetic system is all about rest and digest.
So it does the complete opposite. An increase in motility, and it relaxes the sphincters. This is the digestion engine running at full speed, moving material through, processing nutrients. If you can clearly connect these physical effects back to fight or flight versus rest and digest, you've basically unlocked the entire functional section of the ANS.
We've established the wiring in the resulting actions, but none of this happens without a chemical signal. So let's pivot now to the messenger molecule itself. Acetylcholine.
Right, and coming to our next slide, we can really focus on this master key. For the parasympathetic system and those crucial relay points, the messenger molecule is acetylcholine, or ASHI.
And we have to define the language here. When we talk about systems that use ASHI, we call it the cholinergic system.
Cholinergic. Neurons that release it are cholinergic neurons. It just means using acetylcholine.
And what makes ASHI so important is its incredible universality within the system. This slide highlights 4 critical sites where ASHI is the primary messenger.
And this is huge because if you ever target this molecule with a drug, you are likely affecting all 4 of these sites simultaneously.
Okay, site 1.
All preganglionic fibers. That means every single autonomic signal, doesn't matter if it's going to end up being sympathetic or parasympathetic, it begins with the release of A at that ganglion. AK starts every single autonomic race.
Site 2.
All postganglionic fibers of the parasympathetic system. This is the entire rest and digest final transmission. Once the signal passes the ganglion, the parasympathetic system uses AK again to talk to the heart, the lungs, the gut, and the glands.
Okay, site 3 is the interesting one, the exception.
It's a fascinating exception. Specific sympathetic postganglionic fibers that supply the sweat glands. Now, the sympathetic system usually uses a different messenger, but for sweating, it uses AAH.
Why?
It's just a physiological quirk, but it has real consequences. It means if we give a drug that affects ASHIT, it can cause massive sweating, which is a common side effect we call diaphoresis.
And finally, site 4.
The neuromuscular junction, or NMJ. This is where the motor nerves meet skeletal muscle. AT is the final go signal for all your voluntary muscle contraction.
Wow. So we have one molecule that starts every autonomic signal, controls all of Mr. Chill, makes us sweat, and controls every voluntary muscle movement.
Which is why it's such a massive central target for pharmacology. Everything from, nerve gas to surgical paralysis agents, they all operate on this single molecule.
So to understand how to manipulate it, we have to know how it's made, how it's used, and maybe most importantly, how it's destroyed.
Exactly. Let's look at its life cycle, which is our next slide.
Okay, so this slide lays out the 5-step process of synaptic transmission. We can think of it like writing, mailing, reading, and then shredding a crucial piece of internal mail.
Perfect analogy. Step 1, the message is written. Synthesis. This happens inside the nerve terminal. It needs 2 raw ingredients, choline, which gets recycled, and acetyl-CoA.
And these two are combined by an enzyme.
A very specific rate-limiting enzyme called choline acetyltransferase, or CHAT. CHAT is the architect of the molecule. This creates acetylcholine.
Step 2, the message is put in an envelope, storage.
Exactly. The new IC is actively pumped and packaged into these tiny storage sacs called synaptic vesicles, and they wait right near the terminal membrane, ready to be released.
Step 3, the letter is mailed, release.
When an electrical signal and action potential arrives, it causes an influx of calcium ions.
E++.
This calcium surge is the trigger that causes the vesicles to fuse with the nerve-ending membrane, releasing AC into the synaptic cleft, that tiny gap between the 2 neurons.
Step 4, the recipient reads the message, binding.
AC floats across the synapse and binds to the specific receptors, the locks on the postsynaptic cell, and that triggers the physiological response, whether it's muscle contraction or a drop in heart rate.
And then step 5, which you said is maybe the most critical step for neurological precision.
It is. The message is shredded to keep the mailbox clear. Inactivation. AGI cannot stay bound to the receptor, or the signal would just run continuously. You'd have uncontrolled contraction or a constant low heart rate.
So it's destroyed.
It's destroyed or rapidly hydrolyzed back into its inactive parts, choline and acetate, by the enzyme acetylcholinesterase, or ACE.
And that inactivation step is incredibly fast, isn't it?
It's phenomenal. ACE is one of the fastest enzymes known in biology, and its speed is what allows for the precise millisecond by millisecond control of our heart rate and muscle tone. If a drug blocks AC, it instantly increases the duration and intensity of the AC signal.
Which can lead to disastrous, life-threatening results if it's not controlled.
Absolutely. This highlights why we need to spend a moment, as we do on the next slide, talking about the cleanup crew itself.
Okay, so this next slide introduces the 2 key enzymes that break down ACI, and their difference is a massive factor in clinical practice.
Right. First, we have true cholinesterase, or acetylcholinesterase, ACE. We can call this the AC specialists.
The special.
It's the highly efficient, dedicated message shredder we just described. Its affinity is almost entirely for acetylcholine.
And where is this specialist located?
Crucially, it's found directly at the cholinergic synapses, in the ganglia, and, very importantly, at the neuromuscular junction. It is perfectly positioned to destroy the signal right where it was used, ensuring rapid clearance.
Then we have the other one, pseudocholinesterase.
Also known as butyrylcholinesterase. We call this the generalist cleaner.
The roaming cleaning service.
That's a good way to put it. It's slower than ACE, but it acts on a much wider variety of ester compounds. So it cleans up AC, but also a lot of different drugs.
And this generalist cleaner is found outside the neural junction.
Exactly. In places like the plasma, the liver, and some glial cells in the brain. Its job is less about precision signal termination and more about just general metabolic clearance of circulating compounds.
Okay, now for the vital clinical pearl that makes this distinction so medically essential.
Right. So certain classes of muscle relaxants that we use during anesthesia, specifically one called succinylcholine, are not metabolized primarily by the specialist, AC. They're metabolized by the generalist, pseudocholinesterase.
Okay, so what's the problem?
Well, some patients, due to their genetics, have a partial or even a complete deficiency in pseudocholinesterase.
Oh.
So if you give them a standard dose of succinylcholine, the drug stays active in their system for far longer than it should. instead of a temporary, say, 10-minute paralysis for the surgery.
They suffer a prolonged reaction.
A prolonged reaction. You could be looking at hours of apnea, the inability to breathe independently, long after the surgery is over.
Wow, so the anesthesiologist has to be aware of this genetic possibility.
They have to be. It reinforces why understanding the generalist cleaner is just as important as knowing the specialist.
That's a powerful real-world consequence. Okay, we know the key, AC, and we know the shredder, the cholinesterases. Now let's explore the structures the key must unlock the receptors.
Now, coming to our next slide, we can establish the fundamental rule of pharmacology.
And what's that?
The effect of H depends entirely on the type of lock the receptor it fits into. A itself is the key, but the outcome changes drastically depending on the door it opens. We have two main families of locks, and they're differentiated by their mechanism.
Okay, first up, the muscarinic receptors.
These are the complex smart locks. They're named that because they respond to muscarine, which is a toxin from certain mushrooms. Their mechanism is indirect, it's slow, and it's sustained.
And structurally, what are they?
They're classified as G-protein-coupled receptors, or GPCRs. When HB binds, it doesn't just open a gate directly.
No.
Instead, it activates an associated G protein, which then starts this elaborate chain reaction, a cascade of secondary messengers inside the cell. Think of it like turning a dial that triggers a dozen internal steps before the final effect ever happens.
So because of that internal chemical cascade, their speed and effect are slower.
Slower, longer lasting, and generally more modulatory. They're used for complex internal regulation, like slowing the heart or increasing glandular secretions.
Now contrast that complexity with the nicotinic receptors.
These are the simple gate locks, named for their affinity for nicotine. Their mechanism is direct, fast, and immediate.
And they are structurally different.
Completely. Nicotinic receptors are ligand-gated ion channels. Ligand just means a molecule that binds to the receptor, and here, when H2 binds, the receptor immediately changes its shape and opens a pore.
It's a gate.
It is a gate.
Yeah.
And it allows positive ions, primarily sodium and potassium, to just rush across the cell membrane.
And that rapid movement of ions causes an immediate depolarization, an electrical event.
Right. It's an instantaneous on switch. The speed is lightning fast, making them perfect for immediate nerve-to-nerve transmission, like in the ganglion, or for instant muscle contraction at the NMJ. The lock determines whether the action is subtle or dramatic.
That's a crucial distinction. Okay, let's start with the muscarinic family.
Yeah.
Now, coming to the next slide, we can dissect the complexity of the three major subtypes.
Yes, segment 11 introduces the three main muscarinic subtypes, M1, M2, and M3. And because they rely on G proteins, the body can tailor the internal signal cascade to achieve different results, even though they're all using the same key, AC.
Okay, so let's use our mnemonic structure right away.
Let's do it. One mind, one heart, and three key actions.
Starting with M1, we associate this with the mind and also the start of digestion.
Location. CNS, so it's involved in cognitive functions like memory and learning, also in gastric glands and the autonomic ganglia.
And its function.
Enhances learning and memory, and it promotes strong stomach acid secretion, a key part of rest and digest.
And the mechanism.
M1 operates via the GQ protein pathway, which results in the increase of internal messengers called IP3 and DAY. This is a potent stimulatory cascade. M1 turns things on.
Okay, next up, M2, myocardium, the heart.
Location. Almost exclusively the heart. And its function is that paramount parasympathetic action. It decreases heart rate and contractility by slowing conduction through the SA and AV nodes.
It's the brake pedal.
It is the brake pedal. Its mechanism is the G protein pathway. The I stands for inhibitory.
So it turns things off.
It does two things. First, it decreases the second messenger CMP, which reduces excitability. And second, and most importantly, it opens potassium channels. When potassium rushes out of the heart cell, the inside becomes more negative, making it harder to fire.
That's called hyperpolarization.
Hyperpolarization, which is what slows the heart down.
Okay, finally, M3, the receptor for many places.
Exactly. Location. Everywhere else, smooth muscle and glands are located. So the gut, the bladder, the bronchi, and exocrine glands like salivary and tear glands.
And its function is the wet and squeezy receptor.
Perfect nickname. It promotes smooth muscle contraction, squeezing the gut, squeezing the bladder, squeezing the bronchi and copious glandular secretion, wetting the mouth, wetting the eyes.
And its mechanism.
M3 uses the same GQ pathway as M1 increasing OP3, and DG, so M3 is also fundamentally stimulatory.
So M1 and M3 are stimulatory, M2 is inhibitory.
That's the key distinction. And for pharmacology, it's critical. If a drug targets M3, you can address issues like a lazy gut or an overactive bladder, but you risk side effects like bronchoconstriction and excessive salivation.
That mnemonic one mind, M1, one heart, M2, 3 actions, salivate, urinate, constrict pupils. That's a really quick way to categorize the complex physiological effects.
It organizes the entire response.
Okay, we've covered the slower, complex locks. Let's move to the faster electrical locks. Now coming to the next slide, the nicotinic family.
Right, segment 12 shifts us back to the nicotinic family, the ion channels. They might be simpler in mechanism, but their location and role are absolutely vital for immediate signal relay and voluntary movement.
And we distinguish between 2 types.
We distinguish between NN receptors, the N for neuronal, and NM receptors, M for muscle. Both are fast, but they're located at 2 fundamentally different points in the communication line.
Let's start with the NN receptors, the neuronal ones.
These are the mandatory relay switches. Their location is threefold. The autonomic ganglia, so the connection between all pre- and postganglionic neurons, the adrenal medulla, and the CNS.
And their function is purely transmission.
Purely transmission. They're the pass-through point that gets the signal from the first neuron to the second. And in the adrenal medulla, binding here triggers that massive release of adrenaline and noradrenaline into the bloodstream, creating the hormonal part of the stress response.
Then we have the NM receptors, M for muscle.
These are located exclusively at the neuromuscular junction, NMJ, where those voluntary motor nerves meet skeletal muscle fibers.
And their function is the final on switch that triggers voluntary skeletal muscle contraction.
Precisely. If a surgeon needs to paralyze a patient for an operation, they use drugs that block these NM receptors, ensuring the patient's muscles are completely relaxed.
And the common mechanism for both NN and NM is that rapid, direct opening of the ion channels,
letting positive ions like sodium and potassium flow, causing immediate depolarization. This is why their effects are always acute and dramatic.
Okay, let's pull all 5 receptor subtypes together for a final look. Now coming to our next slide.
Right. Segment 13 is the consolidation, the table that ties together the location, the mechanism, and the ultimate effect of all 5 subtypes. This synthesis is the key to understanding pharmacology.
So if you look across this table, the most critical contrast is the mechanism, isn't it?
It really is. M1 and M3 are stimulatory, turning things on via IP3 and DAG. M2 is inhibitory, turning things off by decreasing CAMP and opening potassium channels. These are the internal, slower regulators.
And then conversely, NN and NM operate purely electrically.
Purely electrically, using the rapid flux of sodium and potassium channels for instant action ganglionic transmission or immediate muscle contraction.
So this contrast is the entire pharmacological mandate.
It is. If a pharmaceutical company wants a slow, sustained change in the body, say a drug to help with dry mouth or a lazy bladder, they have to target the muscarinic receptors.
But if they want an immediate, dramatic, full-body effect like paralyzing a muscle for surgery or instantly blocking nerve communication, they have to target the nicotinic family.
Exactly. The fundamental difference between the smart lock and the gate lock determines the therapeutic approach and the expected speed of onset.
We've built the anatomy, identified the messenger, and cataloged the locks. Now let's test that understanding.
Okay, now coming to the next slide, we have some application questions.
Segment 14 presents the self-check questions, designed to make sure you, the learner, can connect the anatomical structures to the molecular consequences. Let's tackle these 5 key synthesis points.
Okay, Q1. What are the 2 main structural differences between the sympathetic and parasympathetic nervous systems based on origin and fiber length?
Okay, this requires recalling segment 5. The key difference is the sympathetic system uses a thoracolumbar origin from T1 to L3 and has that short preganglionic, long postganglionic fiber structure for mass discharge.
And the parasympathetic?
The parasympathetic system uses a craniosacral origin from the brainstem in S2-S4 and has the opposite structure. Long preganglionic, short postganglionic fibers, which allows for that precise, targeted control.
Perfect. Q2. Acetylcholine, ACE, is the primary neurotransmitter at which 4 key sites in the peripheral nervous system. This tests your memory on the universal nature of alia.
The 4 sites are, 1, all preganglionic synapses in the ANS. 2, all parasympathetic postganglionic synapses. 3, the exception, sympathetic synapses at sweat glands. and 4, the neuromuscular junction.
Excellent. A great reminder of how central this one molecule is.
Yeah.
Q3, what is the role of acetylcholinesterase, ACE, and why is its speed so important for proper nerve function?
Okay, ACE rapidly hydrolyzes and inactivates AC in the synapse, which terminates the signal almost instantly. And its speed is critical because it ensures that signals are brief and precise. If it failed, we'd have a constant, overwhelming signal like a muscle spasm or a fixed heart rate.
The body would lose its ability to react dynamically.
Exactly.
Okay, Q4. A new drug selectively blocks M2 receptors. What is the most direct and immediate effect you would expect to see on a patient's heart rate? This is a synthesis question.
This is a great application question. Okay, so we know M2 receptors are on the heart,
Right.
and their function is to slow the heart. They're the parasympathetic brake. So if we use a drug that selectively blocks M2, we are essentially removing the brake.
And the accelerator is always on.
And the accelerator, the sympathetic system, is always active. So removing the brake allows the sympathetic system to dominate unopposed. So the effect would be an increase in heart rate tachycardia.
That's the exact mechanism of drugs like atropine. Perfect. Okay, last one, Q5. In simple terms, contrast the mechanism of a muscarinic receptor with that of a nicotinic receptor after HE binds.
The muscarinic mechanism is the slower, complex smart lock. It uses a G protein-coupled receptor to trigger an internal chemical second messenger cascade.
And the nicotinic.
The nicotinic mechanism is the faster, simple gate lock. It's a ligand-gated ion channel that directly opens a pore, causing immediate electrical ion flow and rapid depolarization. One is chemical modulation, the other is electrical impulse.
Fantastic. So let's go to our last slide and just synthesize the core principles.
Right. Segment 15 provides the final synthesis, the 4 core takeaways that really encapsulate everything we've covered in this deep dive. These are the organizing principles.
Principle 1, dynamic balance. The ANS is defined by this constant dynamic balance between the accelerator, fight or flight, and the brake, rest and digest. Homeostasis is not static, it's the result of their ongoing tension.
Principle 2, universal messenger. Acetylcholine, HA, is the indispensable communication molecule. It's the universal starter for all ANS activity at the ganglia and the dedicated full control signal for the entire parasympathetic side.
Which makes it an incredibly powerful yet challenging pharmacological target.
For sure. Principle 3, signal precision. The incredible speed and efficiency of acetylcholinesterase, ATE, ensures that neurological signals are fleeting, brief, and precise. This rapid termination allows the body to change its physiological state in milliseconds.
And finally, principle 4, the lock determines the effect. This is really the ultimate lesson for the learner. The consequence of activating this system is completely dictated by the receptor subtype. Targeting the slow, modulatory muscarinic receptors results in totally different outcomes than targeting the fast, electrical, and immediate nicotinic receptors.
And mastering this lock and key system is the gateway to understanding therapeutic intervention.
Absolutely. I mean, understanding the body's autopilot, particularly the cholinergic system, is just foundational knowledge for medicine. Take asthma. Bronchospasm is caused by overactive smooth muscle contraction, which is an M3 effect.
Right.
So we can use specific muscarinic antagonist drugs that block M3 to relax those airways without dramatically affecting the heart, which is M2, or the brain, which is M1.
Or take that heart rate issue we just discussed. If a patient's heart is racing, a physician might use a drug that mimics AC at the M2 receptor to slam the brakes on harder.
And conversely, if a patient needs their muscles paralyzed for hours during a complex surgery, the target is the Nicotinic Nn receptor at the neuromuscular junction for immediate complete blockage of voluntary movement.
We've seen the sheer power of acetylcholine. It controls our memory, our heartbeat, our digestion, our ability to run and breathe, and the entire fight-or-flight relay. The complexity is its lack of natural selectivity.
That's the real challenge. When we use a drug that acts on the muscarinic family, you risk hitting M1, M2, and M3 all at once. You might successfully treat an overactive bladder, an M3 effect, but you cause side effects like a dangerous drop in heart rate from M2 or excessive drooling or vision problems.
That crosstalk is the clinical challenge.
So the final provocative thought for you to carry forward is about the future of drug design. We are constantly striving for ultimate molecular precision. What if we could design a molecule so perfect that it only impacted M3 receptors located in the smooth muscle of the bladder?
You could cure incontinence with zero cardiovascular or central nervous system side effects?
Exactly. That pursuit of highly selective targeting, based on the mechanisms we just detailed, is the driving force of pharmacology in the 21st century.
The search for the ultimate selective key. Thank you for joining us on this exhaustive deep dive into the body's autopilot system. We hope this knowledge sticks with you, and we encourage you to keep exploring the fascinating world of human physiology and intervention. We'll see you next time.
Body's secret messenger, a molecule called acetylcholine, or AAA for short, and more importantly, the powerful, diverse family of drugs, the cholinergic agents, that are designed specifically to manipulate that messenger.
So our mission today is to master signal control.
Exactly. We are taking the complex field of autonomic pharmacology and dissecting it concept by concept. The goal here is to really understand how these highly specific molecules can perform miracles, like, say, restoring sight in glaucoma patients.
Or bringing back muscle strength in someone with profound weakness.
Right, but also how, if they're in the wrong hands, they can act as deadly poisons. We have 15 dense slides from the source material to explore, and we promise you leave here with a complete, logically mapped understanding of this system.
That concept of mastering signal control is really powerful. It suggests we're dealing with systems that are usually, well, they're completely automated. Stuff we never think about.
Like digestion, heart rate tearing up.
Right, and we're essentially learning how to hijack the body's autopilot. Okay, let's unpack this. Coming to the first slide now. Let's start with the star of the show and its many missions.
Okay, so if we start with the fundamentals, think of acetylcholine H as the body's primary rest and digest text message. It's really the opposite of adrenaline.
Adrenaline being that loud, urgent fight or flight alarm.
Precisely. ACHIA manages the crucial, subtle background operations. It's the stuff that keeps your internal engine running smoothly when you're relaxing.
So it's kind of like the maintenance crew that comes in while the rest of the body is taking a break. What's fascinating to me is that this one single messenger seems to deliver two wildly different types of instructions, right?
Yeah, exactly. And that's the key. ACHI is a dual-purpose messenger. It handles two fundamentally distinct types of missions because it talks to two distinct families of receptors. If you can understand the split, you can understand the entire field of cholinergic pharmacology. So we define these as the two main missions. First, you have the Muscarinic mission. This is where ACHI focuses on fine-tuning the organs, mainly through receptors we label M1, M2, and M3.
Okay, and this covers the whole involuntary rest and digest system.
The whole thing. The heart, the glands, the smooth muscle of your gut and your bladder. You know, when we talk about the side effects of these drugs later on, we're almost always talking about the muscarinic mission, just running wild.
And the second mission?
The second is the nicotinic mission. This one requires a much stronger, more direct signal. Nicotinic receptors are located in the nerve junction boxes, we call them ganglia, and crucially, at the skeletal muscle end plates.
So this is less of a background text message and more of a direct, actionable order.
Exactly. This mission is all about muscle contraction and activating other nerve pathways. It's a direct command.
Okay, now here's where it gets really interesting, and the source material flags this as a crucial piece of knowledge that dictates drug design. AAG is inherently a very short-lived message. The system relies on its ability to turn off instantly. Why is that so necessary?
Well, it's a defense mechanism, really. It's a way to prevent signal noise. The body has a built-in delete button right there in the synapse.
A delete button.
Yep. It's an enzyme called cholinesterase, or sometimes acetylcholinesterase. This enzyme is basically a cleanup crew that works faster than you can blink. It rapidly clears AT from the synapse almost as soon as it's released.
And if it didn't do that?
The muscle or the organ would just stay stimulated forever, which is, you know, the definition of signal overload and toxicity.
And that explains why you can't just inject someone with natural acetylcholine to treat a disorder.
Precisely. It breaks down way too fast to be clinically useful systemically. It's just too unstable. So we need drugs that are chemically engineered to be much more stable. And this is the other strategy, we need drugs that temporarily disable that cleanup crew.
Got it. Okay, so now coming to the next slide, let's look closer at those muscarinic effects. Let's really zoom in on what AEC does to the involuntary systems.
Right, so this is the full list of M2 and M3 receptor actions. And honestly, this list is basically the side effect profile you need to memorize if you're using any cholinergic drug. This is what rest and digest looks like when it's fully activated.
So where do we start?
Let's start with the cardiovascular system. This is where we find the M2 receptors. When it hits the heart, M2, it slows the heart rate down. That state is known as bradycardia.
So the M2 receptor is like the regulator, slowing the engine down to idle speed now that the body isn't facing a threat.
Perfect analogy. M2 is primarily located in the cardiac tissue. Now next, if you consider the GI tract and bladder, these are governed by M3 receptors. M3s are also heavily found on glands and smooth muscle.
And stimulation here gets things moving.
It puts them in high gear, it increases gut motility, so the movement of food through your digestive tract, and it increases bladder tone, which helps with urination. It's the waste disposal system and digestion being turned all the way up.
And I see the next point is about glands, also M3.
Yes, and the effects are dramatic. Cholinergic action boosts all secretions. We're talking saliva, sweat, tears. A common clinical summary you'll hear of a patient who's overloaded with cholinergic agents is that they become wet everywhere.
Wet everywhere. Okay, that's a memorable image. What about the eye?
In the eye, M3, there are two major effects. First, it causes constriction of the pupil. We call that miosis, or pinpoint pupils.
And that's for close-up vision, right?
Yes, it's part of that parasympathetic close-up focus. The second effect, which is crucial for medicine, is that it facilitates fluid drainage within the eye. This is an essential concept for understanding how we treat glaucoma. We'll come back to that.
Okay, and the last couple of points are airways and blood flow.
Right. On blood vessels, M3, HE causes vasodilation, which generally lowers blood pressure. And in the lungs, M3, it does two things. It constricts the bronchi, that's bronchoconstriction, and it increases the secretions in the airways.
And that leads directly to a critical safety note drawn right from the source material.
The ultimate contraindication.
Because these drugs cause bronchoconstriction and dramatically increase lung secretions, they can be incredibly dangerous in patients with underlying respiratory conditions.
Like asthma or severe COPD. You are essentially drowning the patient in their own secretions while shutting down their airways. Understanding these M2 and M3 actions is the foundational step. It's what we'll later call the dumb ALS side of the equation when we get to poisoning.
Okay, now coming to the next slide. Let's consider the nicotinic side, which you said is fundamentally different.
Totally different. If the muscarinic signal is the quiet text message, the nicotinic mission is escalating to a direct order. The effects here are complex, they require high concentrations of HA, and they happen in two key, very powerful places.
And the first one is the autonomic ganglia.
The autonomic ganglia. This is the critical junction box where nerve signals destined for the organs are routed. And here's the tricky part. HA stimulates both the sympathetic fight or flight and the parasympathetic rest and digest nerves here.
Wait. Both at the same time?
Both at the same time. And because you're stimulating both systems simultaneously, you get these complex, mixed effects that can be unpredictable. It's a massive, confusing signal sent to the body, which might show up as, say, initial tachycardia and elevated blood pressure.
That does sound confusing. What's the second site?
The second and honestly most devastating site is the skeletal muscles. We're talking about the voluntary muscles that control all your movement, including breathing. When high concentrations of A hit the nicotinic receptors, the NM receptors here, it causes a very specific and frankly terrifying sequence of events.
Let's talk about that sequence. What's the difference between just a twitch and actual paralysis?
Well, initially, the muscles just fire wildly. You see these rapid, uncontrolled twitches. The medical term is fasciculations, but this very quickly leads to paralysis.
Why? How does overstimulation lead to no stimulation?
Because the overwhelming concentration of ASHI forces the muscle to remain continuously stimulated. We call this state prolonged depolarization. Think of the muscle fiber like a car engine. The initial signal turns the ignition key.
Right.
But a high dose of ASHI gets the key stuck in the start position. The engine turns over once, but it can't return to the off position to reset and wait for the next signal. Since it's continuously on but not actually moving, it locks up. It becomes paralyzed.
That is terrifying, especially when you think about the diaphragm and other respiratory muscles. That has to be the immediate cause of death in severe poisoning.
It is. But here's a crucial concept that comes up next, one that divides our cholinergic agents into those that act in the brain and those that act only in the body. The critical barrier.
You're talking about the blood-brain barrier.
Yes, the blood-brain barrier, or BBB. Natural AC is a charged molecule. Chemically, it's a quaternary ammonium compound. And because it carries an electrical charge, it does not cross the blood-brain barrier easily. It can't just sneak past the fatty cell membranes that form the BBB.
And this is fundamental in pharmacology, right?
Absolutely. Charged water-soluble molecules act almost entirely peripherally so, outside the brain and spinal cord. But uncharged, lipid-soluble, or fat-loving molecules can slide right across the BBB. This single difference dictates which drugs can treat central effects and which are confined to the body.
Okay, that's a perfect transition. So since the body's natural delete button is so fast, we need stable, long-lasting drugs for any kind of therapeutic effect. So now coming to the next slide, how do we get there? How do we move from this unstable natural messenger to effective pharmaceutical manipulation?
Well, if we decide we need to boost that AC signal, say to restore muscle function or relieve eye pressure, we have two distinct strategies. And these form the two major classes of cholinergic agonists. We can either impersonate the messenger or we can amplify the message.
Impersonate or amplify. I like that. Let's start with the impersonators.
Okay, the first pathway is the directly acting agonists. These are the impersonators. They're chemically engineered to look like eye, but they're much more stable, which means they resist being immediately chopped up by cholinesterase.
So they bind directly to the receptor site and kick off the signal themselves.
They do. They successfully impersonate the original messenger. And our sources categorize these impersonators into a couple of chemical subclasses.
Okay.
First, you have the cholinesterase. These are synthetic molecules based on the ACTI structure, like bethanechol and carbachol. They are basically stabilized versions of IHI. And then you have the alkaloids, which come from natural plant sources.
Like what?
Like pilocarpine, which comes from the jaborandi plant, and the toxic mushroom compound muscarine.
Got it. So that's the impersonators. What about the amplifiers?
The second major pathway is the indirectly acting agents, or anticholinesterases. These are the amplifiers. They don't try to mimic ATA or bind to the receptor. Instead, they disable the enzyme, they break the delete button.
So they break the cholinesterase.
Exactly. And the result is that the body's own HE sticks around much longer in the synapse. This makes the natural signal louder, stronger, and longer lasting.
And within those amplifiers, there's a critical distinction based on permanence. This seems to be what separates life-saving medicine from lethal nerve agents.
It's everything. We classify the indirect agents into reversible and irreversible. The reversible agents, like the carbamates, that includes neostigmine,
Right.
and those used for memory enhancement like donepezil and galantamine, they only temporarily inhibit the enzyme for a few hours.
And the irreversible ones.
The irreversible agents are the villains. These are the organophosphorus compounds, or OPs. They stop that cleanup crew permanently.
Okay, let's focus on the impersonators first. Coming to the next slide now, the direct-acting agents. These are the drugs that deliver that stable, reliable message. We're looking at selective manipulation here, right? Often targeting just the muscarinic receptors to avoid dangerous side effects.
That's the goal. And to illustrate this, let's meet two specific drug heroes, bethanechol and pilocarpine.
All right, so bethanechol, what's its specialty?
Bethanechol is the gut and bladder specialist. It's a choline ester that's been chemically altered, so it is highly resistant to being deleted by cholinesterases. And crucially, it selectively stimulates muscarinic receptors, particularly the M3s that govern smooth muscle tone.
And when would a doctor need to, well, restart a sluggish system like that?
Clinically, its primary mission is to force those involuntary muscles to contract. This is critical for conditions like postoperative urinary retention, when a patient can't pee after surgery because the bladder muscle is temporarily dormant. It's also used for something called paralytic ileus, where the gut movement slows down or stops completely after abdominal surgery. Bethanechol essentially wakes those systems up and forces them to get moving again.
So if we want a reliable mnemonic for that, I remember one from the source material, bethanechol helps you be toilet happy.
Ha! That's an excellent application. It works perfectly. It forces the gut and bladder to run efficiently.
All right, so what about the other one, pilocarpine?
Now, pilocarpine is the eye expert. This is a natural alkaloid. It also stimulates muscarinic receptors, and it's highly effective when you apply it locally to the eye, like in eye drops.
And its main mission?
Its primary mission is to relieve pressure inside the eye. It is a key treatment for open-angle glaucoma because it increases the drainage of the fluid inside the eye, the aqueous humor. The mechanism is fascinating. It's a physical change caused by muscle contraction, which we'll detail in a bit.
Okay, so let's synthesize the mnemonic hack for these two direct agonists. Bethanechol makes you be toilet happy for the gut and bladder. And pilocarpine acts on the pupil and intraocular pressure, the IOP.
And there you have it. The chemical impersonators are all mapped out.
Great. So now coming to the next slide, let's talk about the indirect agents. the amplifiers. This is a totally different approach.
Completely different pharmacological strategy. They do not mimic AA. They simply disable the enzyme, the cholinesterase, that destroys it. The result is a high concentration of the body's natural AHA flooding the receptors.
And this is where the chemistry of time comes into play. The duration of action depends entirely on how stable the bond is that the drug forms with that enzyme. We're moving through different levels of disabling that delete button.
That's a great way to put it. What's fascinating is that the cholinesterase enzyme isn't a simple target. It has an anionic site and an esteratic site. Different drugs attack these sites in different ways, and that leads to 3 distinct durations of action that govern how they're used clinically.
So what's the first level, the shortest one?
First, we have edrophonium. This is ultra short acting. We're talking 2 to 5 minutes. That's it. It just briefly covers the delete button by binding reversibly and very transiently to the anionic site of the enzyme.
So with that fleeting action, it's not for treatment.
No, it's only useful for immediate diagnosis, not for sustained therapy.
Okay, what's the next step up?
Second are the carbonates. This group includes agents like neostigmine and pyridostigmine. These gum up the button for a few hours. They temporarily acetylate the enzyme at its esteratic site. It's a reversible bond, but it's stable enough to last for a few hours, which makes it suitable for daily dosing.
And the third group? These are the permanent ones.
Third are the organophosphates, the OPs. These are the permanent villains. They smash the button permanently by causing irreversible phosphorylation of the enzyme. They form an extremely stable covalent bond.
So the body can't reverse that damage.
It can't. It has to synthesize brand new cholinesterase from scratch, which takes days or even weeks. And that permanence is precisely why OPs are so devastatingly toxic.
Okay, let's dive deeper into the reversible agents. On the next slide, we're contrasting 2 of them, and their utility seems to hinge entirely on that chemical difference we talked about earlier.
Yes, their ability to cross the blood-brain barrier. This comparison between physostigmine and neostigmine is essential. It dictates exactly where they can be used, particularly in toxicology and specific diseases.
So let's start with physostigmine. The source calls it the covert agent.
Right, and look at its chemistry. It is a tertiary amine. This means it is lipid-soluble or fat-loving. Think of it as being uncharged, like oil, and because of that structure, it can easily slide right across the blood-brain barrier.
Which means its effects are central and peripheral, and this gives it a unique, life-saving mission.
A top-secret mission, in fact. Its main use is treating severe poisoning by anti-cholinergic drugs, the drugs that block ACTIO, like atropine. So atropine poisoning causes severe peripheral symptoms, like dry mouth and rapid heart rate, and central symptoms like confusion, delirium, even coma. Physostigmine is the preferred antidote because it crosses the BBB to reverse atropine's effects in the brain as well as in the body.
Now contrast that with neostigmine, the muscle specialist.
A completely different chemical structure. Its chemistry is a quaternary ammonium compound. It carries an electrical charge. Think of it as a water-soluble brick. Because it's charged, it is not lipid-soluble and does not cross the BBB.
So neostigmine is confined to the body. It acts only peripherally.
Correct. Its mechanism is to reversibly inhibit cholinesterase peripherally, which amplifies the body's natural OSH. But here's an important detail. Neostigmine also has a unique, direct stimulating effect on nicotinic receptors at the neuromuscular junction.
Wait, so it does 2 things.
Yes, it isn't just turning up the volume by amplifying ASHA, it's also physically pressing the button harder with that direct stimulation. And that's exactly what you need when the muscles are barely responding, like in myasthenia gravis.
That makes the choice really clear based on location. So the mnemonic hack from the source material to keep these 2 straight, physo-height, physiological systems, meaning it goes everywhere, including the brain.
And neostigmine is not enough to cross the organization, the BBB. Knowing which drug crosses the BBB is absolutely critical for toxicology.
Okay, we've built a really solid theoretical framework. Now, coming to the next slide, let's apply it to some real-world clinical problems, starting with a mission to save someone's sight.
Right, let's talk glaucoma.
Glaucoma is terrifying. It's optic nerve damage, often from chronically high intraocular pressure or IOP. For anyone not familiar, it might be helpful to think of the eye's internal plumbing, like a sink.
That's a perfect analogy. The eye produces a clear fluid called aqueous humor, which constantly drains out through a filter system called the trabecular meshwork.
So that's the drain.
That's the drain. And glaucoma occurs when that drain gets partially or completely clogged. The fluid keeps being produced, but it can't exit. So the pressure builds up, and it slowly crushes the delicate optic nerve fibers in the back of the eye, leading to blindness.
And this is where pilocarpine comes in.
This is where pilocarpine shines. As a direct-acting muscarinic M3 agonist, its mechanism is purely mechanical. It works in 3 steps. First, it contracts the ciliary muscle, which is a tiny involuntary muscle located just behind the iris. Second, that physical contraction pulls on the structures anchored to it, specifically pulling open the trabecular meshwork. It physically widens the drain.
And third, the fluid drains better.
Exactly. Aqueous humor drainage improves significantly, and that lowers the intraocular pressure.
It's amazing that a tiny chemical signal can cause a physical change that prevents blindness. But we should probably mention, this is rarely the only solution, right?
Oh, that's crucial context. While pilocarpine is powerful, glaucoma management is almost always combination therapy. Doctors might also use beta blockers, which reduce the actual production rate of the fluid, or prostaglandin analogs, which help increase an alternative drainage pathway. But pilocarpine's direct mechanical action remains a cornerstone for reducing pressure quickly.
Okay, now for the next slide. This brings us to our second major application, a disease of profound muscle weakness.
Myasthenia gravis, or MG. This is a classic example of an autoimmune disorder. The immune system mistakenly targets and destroys the body's own infrastructure. In this case, the antibodies attack and destroy the nicotinic receptors at the neuromuscular junction.
So the messenger, the HOs, is still being released, but the receiving station has been, well, it's been bombed out.
Exactly. When the nerve releases its signal, there are simply fewer places for that message to land. The signal that reaches the muscle is weak, and that leads to profound muscle weakness and fatigue. Patients often present with drooping eyelids, what we call ptosis or difficulty swallowing, or just generalized severe fatigue that gets worse with activity.
And this leads us to a critical life or death decision point that the source material highlights, the diagnostic moment.
The edrophonium test. Because MG patients need long-acting cholinesterase inhibitors like neostigmine to maintain their strength, sometimes their weakness gets worse. And the doctor has to figure out, is this worsening weakness because the disease is progressing a myasthenic crisis, which needs more drug?
Or is it because of too much drug, a cholinergic crisis,
Yeah.
which leads to that prolonged depolarization of paralysis we talked about?
Exactly. It's a critical distinction.
Wait, if a high concentration of the drug causes paralysis, how do doctors possibly separate the cure from the overdose? How do you use a drug to diagnose a drug overdose?
You use edrophonium, the ultra-short-acting one. Since it only lasts 2 to 5 minutes, it provides a brief, temporary test dose of amplification. A small 5e dose is given. If the patient's weakness dramatically improves for those few minutes.
Then it was the disease.
Yeah,
They need more of the long-acting drug.
correct. The diagnosis is a myasthenic crisis. The brief volume increase hit the few remaining receptors effectively. But conversely, if the weakness worsens after the dose, you confirm a cholinergic crisis. They already have too much drug, and adding edrophonium just pushed them further into dangerous paralysis.
So the test provides an immediate transient answer that you need for a critical long-term treatment adjustment.
That's right. And once that test confirms the disease, the treatment then switches to the longer-acting reversible amplifiers.
Right, for sustained relief.
Yes. For sustained symptomatic relief throughout the day, the longer-acting reversible anticholinesterases, primarily neostigmine and pyridostigmine, are used. They provide that continuous, low-level amplification of the body's natural innaceous signal, maintaining the strength required for daily life.
Okay, we've talked about restoring strength and sight, but now we have to confront the fact that in pharmacology, the difference between life-saving medicine and a lethal poison, well, it's often just the stability of a single chemical bond. So coming to the next slide, we have to shift dramatically now to toxicology.
We have to talk about irreversible organophosphate poisoning. Organophosphates, or OPs, are notorious. They're common in certain agricultural insecticides, and chillingly, they are the chemical structure behind modern nerve agents like sarin and VX.
Can you explain that deadly mechanism one more time? It's all about that irreversible bond.
Unlike our therapeutic drugs, OPs form an extremely stable covalent bond with the cholinesterase enzyme. They are highly reactive molecules that permanently attach a phosphate group to the enzyme's active site. We call this phosphorylation.
They don't just gum up the button.
No, they smash it permanently. They render that specific enzyme molecule useless forever.
And the consequence of that is catastrophic.
It is. With the cleanup crew permanently disabled, you get a massive, uncontrolled flood of ASHEA at all the muscarinic and nicotinic sites across the entire body. And this leads to a body-wide state of overstimulation called a cholinergic crisis.
Okay, now to the next slide. This brings us to the urgent task of recognizing these symptoms quickly.
The clinical presentation is severe. The patient is often summarized clinically as being wet everywhere and can't breathe. And to organize the severe muscarinic effects, all those rest and digest systems running wild, we rely on the famous dumbbells mnemonic.
Okay, let's walk through this crucial diagnostic tool for the listener. This covers the muscarinic symptoms one by one.
Right. So D stands for severe diarrhea from that uncontrolled gut motility.
Okay.
U stands for urination, so incontinence. M is for meiosis, those pinpoint pupils, a classic sign.
And there are two Bs.
Two Bs. The first B is for bradycardia, that slow heart rate. The second B is for bronchospasm, which is severe airway constriction, and also for increased bronchial secretions in the lungs.
Next is E.
E is for emesis, which is just vomiting. L.
L is for lacrimation, so profuse tearing, and also potentially lethargy or confusion from central effects if the specific OP compound crosses the BBB.
And finally, S.
And S is for excessive salivation and sweating. That's the wet everywhere component.
So that covers the so-called nuisance effects, the heart, gut, and glands. But those aren't usually what kill the patient, are they? We need to emphasize the lethal nicotinic and CNS components.
Absolutely vital. While dumbbells is dramatic, the patient dies from failure in two other systems. The nicotinic effects at the skeletal muscle cause those initial fasciculations, which rapidly progress to total paralysis due to prolonged depolarization.
The stuck ignition switch.
The stuck ignition switch. And this includes paralysis of the respiratory muscles, specifically the diaphragm. This is the ultimate cause of death, the inability to breathe.
And there are also CNS effects?
Yes. Depending on the OP compound structure, we can see severe CNS effects, confusion, seizures, coma, and central respiratory failure. The toxicity is total system collapse. The good news is that we have effective antidotes. But the treatment plan, according to this next slide, is a very precise two-pronged attack.
That's right, a two-pronged attack.
So why do we need two drugs? If the problem is just too much ARC, why can't one drug solve it all?
Because we have to treat two completely different biological problems caused by that ASHA flood. We have to treat the muscarinic symptoms, the dumbbells and the heart rate, and we have to treat the lethal nicotinic paralysis, the muscle function.
Okay, so antidote number one.
Antidote one is atropine. We call this the receptor earmuffs.
The receptor earmuffs, I like that.
Atropine is a competitive antagonist. It physically sits on the muscarinic receptors, and it blocks the overwhelming flood of atropine from delivering its message.
Oh.
It essentially silences the rest and digest system, drying up all the secretions and speeding up the heart.
So atropine treats the dumbbells. If a farmer is brought in with OP poisoning, atropine will save them from drowning in their own secretions and correct the bradycardia.
Correct. But here is the critical limitation. Atropine does absolutely nothing to fix the paralyzed skeletal muscles.
Because it only works on muscarinic receptors.
Exactly. Since atropine is only a muscarinic antagonist, it does not interact with the nicotinic receptors responsible for muscle function. If the patient is paralyzed, atropine won't help them breathe or move at all.
And that's why we need antidote number two.
That's why we need antidote two. Pralidoxim, which is an oxum, also known as 2-PM. This is the enzyme supermechanic.
So this drug is specifically designed to fix the problem at the source, to repair that smash delete button. How does it physically manage to yank off the permanently attached organophosphate molecule?
Pralidoxim is a work of chemical genius. It has a high affinity for the OP molecule when it's stuck on the enzyme. It attaches near the phosphorylation site, and through a chemical reaction, it physically pulls the OP compound away from the cholinesterase enzyme. It frees the enzyme to start working again.
And this reactivation is what reverses the paralysis.
It's the only thing that reverses the lethal nicotinic effect of muscle paralysis. However, and this is a big however, there's critical timing for pralidoxim. It's a concept known as aging.
Aging.
Yes. When the OP molecule first attacks the enzyme, it's sitting there with a temporary unstable weak spot. If we can get pralidoxim in quickly, ideally within the first few hours, it can interrupt the process and reactivate the enzyme.
And what happens if you wait too long?
If too much time passes, the OP enzyme bond undergoes a chemical change. It ages, and the bond becomes absolutely permanent and irreversible. Once that bond is aged, pralidoxim will no longer work. The timing window is truly life or death. Atropine keeps the patient alive by managing the heart and secretions, but pralidoxim is the only drug that can reverse the paralysis and let the patient breathe on their own again.
That was a powerful journey through the system. We've mastered the messenger, understood the amplifiers, and learned the rescue plan for system collapse. Now, coming to the next slide, let's synthesize everything we've learned by tackling 3 key real-world clinical scenarios. This is where you, the learner, can apply your knowledge of drug mechanisms, durations, and that all-important BBB crossing.
All right, these are your final mission briefings. Q1, MG crisis versus cholinergic crisis. A myasthenia gravis patient reports worsening weakness after increasing their pyridostigmine dose. How do you quickly determine if they need more drug, a myasthenic crisis, or if they have too much drug, a cholinergic crisis?
This requires knowing the properties of one very specific ultra-short-acting drug we mentioned.
Okay, Q2. Physostigmine versus neostigmine. Why is physostigmine and not neostigmine the preferred anticholinesterase for treating severe poisoning with a drug like atropine? You have to think about the location of the poisoning.
Right, where the problem is happening.
And finally, our toughest toxicology question, which brings the whole rescue plan together. Q3. OP poisoning treatment sequence. A farmer has OP poisoning. You administer atropine. It successfully dries up his secretions, speeds up his heart rate, and improves his blood pressure. But his muscle paralysis remains. He still cannot breathe on his own. What is the next essential time-sensitive step, and why?
All right, let's get into it. Now, coming to the final slide, let's provide the definitive answers, ensuring these critical concepts are permanently ingrained.
Okay.
So starting with A1, the MG crisis dilemma, the test dose.
A1 is for the MG crisis. The solution is to administer a small IV dose of edrophonium. The ultra-short duration is the key. If the weakness improves, even for those brief few minutes, it confirms myasthenic crisis. They need more drug.
And if it gets worse,
if the weakness worsens dramatically after the dose, it confirms a cholinergic crisis. They already have too much drug, and the temporary amplification only pushed them further into paralysis.
it's a brilliant way to get a yes or no answer in just 2 minutes. Okay, moving to A2, the importance of the chemical structure.
A2 is for atropine poisoning. Atropine's toxic effects happen centrally in the brain, causing delirium and confusion, and peripherally. To effectively reverse the poisoning, you need a drug that can treat the central effects.
Which means it has to cross the BBB.
Exactly. Therefore, physostigmine is required because it is lipid-soluble and crosses the BBB. Neostigmine cannot cross the barrier and would fail to reverse the lethal and damaging effects on the central nervous system.
And finally, A3, the persistent paralysis and OP poisoning, which shows why that two-pronged approach is completely non-negotiable.
Right. A3 is for OP poisoning. The next essential step is administering pralidoxim, 2 PAM. You solve the muscarinic crisis with atropine. You fix the wet symptoms in the heart. But the atropine has done nothing for the paralyzed muscles, the nicotinic effects.
So you need the enzyme supermechanic.
You need pralidoxim immediately to reactivate the cholinesterase, reverse the paralysis, and allow the patient to breathe again. Every single minute counts to ensure that bond hasn't aged.
And this brings us to the core takeaway.
The core takeaway is this. The ability to control the autonomic nervous system is all about understanding the role of a single messenger, acetylcholine. We've seen how we can chemically impersonate it, like with bethanechol or pilocarpine.
How we can amplify its natural signal with drugs like neostigmine or edrophonium.
Or how we can block it entirely with something like atropine. This mastery allows us to restore incredibly fundamental biological functions, opening the drain in the eye to restore sight, turning up the volume on remaining receptors to return muscle strength, and using that enzyme supermechanic to reverse deadly poisons.
That was an incredible deep look into a system that really governs life and death. Moving from a simple rest and digest text message all the way to understanding the precise timing needed to battle the most sophisticated nerve agents is just staggering. The amount of critical insight packed into controlling this one-molecule signaling system is truly humbling.
It's true, and if we connect this to the bigger picture, it raises an important question for you to consider long after this deep dive concludes. The tension between life-saving pharmacology and lethal toxicology often comes down to the stability of a single chemical bond, whether that bond with the enzyme can be broken and reversed, or if it is permanent and irreversible. So my question is, why is it that the pursuit of chemical stability always seems to lead to both the best and the worst outcomes in medical science?
A truly provocative thought to end on. Thank you for joining us for this deep dive into cholinergic agents. We hope you now feel fully equipped to understand the high-stakes language of the body's secret messenger. We'll see you next time. And today we are diving into one of the most foundational, um, really powerful pharmacological systems in the human body.
We're talking about a system of internal signaling that, keeps you calm, processing food, and conserving energy.
We're talking about the master key system, acetylcholine, and what happens when modern medicine decides to step in. We're exploring anticholinergic drugs, these specialized chemical blockers that are designed to interrupt those vital signals to treat, well, everything from asthma to an overactive bladder.
Okay, let's unpack this. We have a really robust stack of 16 detailed slides here, and that's going to be our blueprint for today. Our goal is to go through the structure exactly, not skipping a single term or drug.
Right.
We're going to explain every principle from the basic biology of the key and lock analogy right up to the advanced, highly specialized drugs used in clinical practice today.
And we'll be paying special attention to chemical structure because, as you can see, whether a drug crosses the brain barrier or not it's the single most critical organizational principle in this entire class of drugs.
This deep dive feels really essential because these drugs they're everywhere.
Oh, absolutely. You might be taking one for IBS, or maybe an elderly relative is using one for COPD.
So understanding why these common medications work, why they cause those classic side effects like dry mouth, and why pharmaceutical science has pushed so hard for precision, that's the key here.
It really is. So let's jump in and start with the foundational idea.
Okay, so let's turn to our very first source, our first slide. It's titled The Master Key and the Blockers, a guide to anticholinergic drugs, and it sets up the perfect analogy right from the get-go. Right there in the slide visual, you can see acetylcholine, or ATO, visualized as this golden, intricate master key, and then the muscarinic receptor as a sturdy, complex lock.
And that visual is the elegance of human physiology, just distilled into one image. Acetylcholine is the body's natural, essential signal. It's the messenger.
And the muscarinic receptor is the lock that accepts that messenger.
Exactly. When the key turns the lock, a specific physiological command is executed. The smooth muscle contracts, or the heart slows down, or a gland secretes some kind of fluid.
So our whole discussion today revolves around safety, then. How we can selectively introduce a blocker that interferes with this vital lock and key mechanism to treat a disease.
Without causing catastrophic system failure, yes.
It sounds like a really delicate balancing act. You're intentionally disabling a part of the body's fundamental command structure.
It is delicate, which is why precision is so paramount. We need drugs that can safely occupy these locks and prevent the body's own key from working, but only in the places we want and for the duration we intend.
That sets the stage perfectly. Now, coming to our next slide, let's go deeper into the biology of that master key itself. Slide 2 introduces us fully to the body's universal messenger, acetylcholine. Let's formally define it. What is ETAW and what's the scope of its control?
Okay, so acetylcholine, ATA, is one of the primary neurotransmitters in your entire body. A neurotransmitter is just a chemical molecule that nerve cells use to communicate with other cells.
Could be muscle cells, gland cells.
Right, or even other nerve cells. And when we call it the master key, we are referring specifically to its role in the parasympathetic nervous system, or the PNS.
The PNS, that's the classic rest and digest mode, isn't it?
Absolutely. Think of your nervous system as having two major branches that regulate all the automatic unconscious body functions. The sympathetic system is your fight or flight. It ramps up the heart, diverts blood.
And the parasympathetic system, which is driven by ETAW, is the complete opposite.
The complete opposite, the rest and digest system. It tells your heart rate to slow down. It ramps up the production of digestive enzymes, increases gut motility.
Right.
It generally promotes the conservation and processing of resources.
And these commands are executed by those locks we talked about, the muscarinic receptors. You mentioned that atropine, the prototype drug we're going to discuss, blocks all of them. Can we briefly outline what each major subtype M1, M2, and M3 actually controls?
Yeah, that's a great idea, because understanding these subtypes it's the master key to understanding specialization later on. The muscarinic receptors are the protein structures on the target cells that respond to HE.
Okay.
So M1 receptors. These are primarily found in the nervous system, including ganglia and, critically for drug development, in the gastric glands, where they help stimulate the secretion of stomach acid.
So M1 is acid? What about M2?
M2 receptors are the cardiac controllers. They are heavily concentrated in the heart, and when AP activates them, they execute the command to slow the heart rate down. They are the body's natural cardiac brake. M3 receptors are the widespread functional workhorses. They are found on exocrine glands, so that's your sweat, salivary, lacrimal glands, and on smooth muscle, the gastrointestinal tract, the bronchi, and really importantly for quality of life, the smooth muscle of the bladder wall.
That's a fantastic bit of context. So M1 for acid, M2 for the heart rate, and M3 for nearly all the secretions and smooth muscle movement.
You got it.
The diagram on the slide shows the whole action happening at the synapse, the nerve terminal releasing HF, which then crosses a tiny gap to turn those M1, M2, or M3 locks on the target cell. It's high-speed, high-stakes messaging.
Exactly. And if you want to stop that command, say you want to stop the stomach from producing too much acid or the bladder from contracting too often, you need to jam those locks.
Okay, so how do we jam the lock without breaking it?
Well, that brings us right to our third slide, when the wrong key gets stuck in the lock. This is the core concept of pharmacological antagonism.
Anticholinergic drugs are identified here as antagonists. That definition is crucial. They are opponents, right? They don't switch anything on.
Precisely. They are fundamentally blockers. They're designed not to mimic the natural key, HE, and activate the receptor. That would make them an agonist. But rather to fit so perfectly into the receptor site that they block the natural key from binding.
So the shape is similar enough to fit the keyhole, but the internal geometry it's wrong.
That's the simplest way to put it.
Yeah.
We define this as competitive antagonism.
Yeah.
Think of the muscarinic receptor as this incredibly specific, custom-machined lock. The body's key, HE, fits and turns the mechanism. The anticholinergic drug is synthesized to look chemically similar enough that it just slides right into that keyhole. It occupies the space perfectly, but because it lacks the correct molecular angles or charges, the ridges on the key, so to speak, it cannot turn the lock or execute the command.
So by simply occupying the keyhole, the drug prevents the genuine master key, the HE molecule, from even reaching the receptor. The signal is just canceled.
Yes. And because it's competitive, the degree of antagonism is really a chemical tug of war. If you have a high concentration of the blocking drug, you win, and the PNS signal is silenced.
And what if you have a lot of the natural key?
Right. If the body produces an overwhelming amount of natural ACE in a poisoning scenario, then the natural key will eventually outcompete the drug and bind to the few locks that are left unoccupied. That concentration dynamic is why dosing is so important.
This whole concept of jamming the lock leads us directly to the original non-selective master jammer, the drug that really taught us everything about the side effects of this entire class.
It sure did.
Okay, now coming to the next slide, we're transitioning from the theoretical mechanism to the chemical reality. We're now profiling atropine, the original muscarinic blocker.
Atropine is, without question, the archetype. Its history is just as compelling as its pharmacology. It's a natural alkaloid extracted from the Atropa belladonna plant.
Deadly nightshade.
Deadly nightshade, exactly. Known for centuries. The toxicity is legendary, but so is its therapeutic power when you harness it correctly.
And chemically, we need to focus on one crucial detail right away. It's a tertiary amina. Why does that matter so much?
That tertiary amine structure is the absolute key to its systemic effect. It means the molecule is largely uncharged and therefore highly lipophilic or fat-soluble.
And because it's fat-soluble?
It can easily slip through lipid membranes, including the great protector of the brain, the blood-brain barrier, or BBB. We need to internalize this insight right now. If it's a tertiary amine, it goes everywhere, including the brain. If it goes everywhere, it causes widespread side effects.
So atropine's mission is just non-selective blockade. It's the sledgehammer.
Precisely. It blocks the action of HEA on all muscarinic receptors, M1, M2, M3, everything. So if you are trying to achieve one specific effect, say speeding up a dangerously slow heart, you're guaranteed to get every other effect too.
The dry mouth, constipation, blurry vision.
The whole package.
And the administration notes confirm its versatility. You can use it topically for the eye, orally or parenterally through injection. All viable options thanks to that lipophilic structure. It's a systemic drug no matter how it enters.
It is an absolute powerhouse. And that power is really evident when we look at its physiological impact.
Okay, now coming to the next slide. Let's delve into the specifics of its action, starting with the brain, the central nervous system. CNS. The fact that atropine is a tertiary amine means it crosses that blood-brain barrier, making CNS effects pretty much unavoidable.
Right. At a controlled therapeutic dose, these central effects can actually be beneficial. You see a mild CNS stimulation.
And this is why it can be used clinically?
Exactly. It's used to reduce the tremor and rigidity associated with Parkinsonism. It helps rebalance the chemistry and the deep structures of the brain. It's also used to suppress the signals associated with motion sickness, acting on the central vestibular pathways.
But the slide clearly labels the consequences of high doses as a danger. The line between therapeutic and toxic here seems very, very thin.
It is razor thin. Once high doses cross the BBB, that CNS stimulation turns pathological. You see excitement, agitation, profound confusion, terrifying hallucinations.
Mad as a hatter.
That's the classic phrase, which we'll get to. If the dose is massive, it suppresses the vital centers in the brainstem, leading rapidly to medullary paralysis, coma, and ultimately death. This is why plant poisoning involving atropine or its relatives is a huge medical emergency.
Okay, moving from the brain to the heart, the cardiovascular system, CVS. This is where things get genuinely counterintuitive. At low doses, atropine causes an initial slowing of the heart, bradycardia. Why does a drug whose main job is to block the slowdown signal actually cause the heart to slow down first?
Okay, this is a critical point that trips up so many students of pharmacology, but it's a brilliant example of a feedback loop. Think of the nerve terminal that releases acetylcholine as having a little self-regulating sensor on it, an M1 autoreceptor.
A sensor on the nerve itself.
Yes. When the nerve terminal releases enough ash, a tiny bit of that ash binds to its own M1 autoreceptor, telling the nerve, hey, stop releasing more ash, we have enough. It's an internal brake on the release process.
And atropine blocks that internal brake.
Exactly. At very low doses, atropine blocks those presynaptic M1 autoreceptors before it gets to the main M2 receptors on the heart muscle itself. So when you block the nerve terminal's internal brake, the nerve terminal releases a brief, temporary surge of more natural HE.
Ah, so the body accidentally floods the system with its own messenger.
Right. And that surge briefly overwhelms and activates the M2 receptors on the heart, causing that transient bradycardia.
Fascinating. But then the main effect takes over.
Yes. Once the therapeutic dose is reached, the primary action prevails. Atropine floods the M2 receptors directly on the heart tissue, blocking them completely. Since the M2 receptor is the body's natural brake on the heart, blocking it removes that brake, resulting in tachycardia, a fast heart rate. It also improves the speed of electrical signals moving through the heart.
So in an emergency where a patient's heart is dangerously slow, atropine is a rapid, life-saving tool precisely because of that non-selective M2 blocking power.
It is the cornerstone for treating certain types of pathological bradycardia. Absolutely.
Okay, now coming to our next slide. We have to address the consequence that impacts patient comfort and compliance the most, the signature drying effect. This is where that M3 receptor block really shows its face across the entire body.
This is the definitive peripheral sign of non-selective anticholinergic use. The primary mechanism is this profound reduction of secretions, controlled largely by M3 receptors. We are, in essence, shutting down the body's fluid output.
And the list of blocked secretions is vast. Sweat, saliva, tears, bronchial, nasal, gastric fluids.
The clinical result is a patient who is literally dry throughout the body. Dry mouth, or xerostomia, is the complaint 99% of patients on these drugs will report. It can severely impact quality of life and, whether they even stick with the treatment.
The reduction of sweat is also critical, right?
Oh, absolutely. It directly leads to hyperthermia or overheating, which can be dangerous, especially in the young or the elderly.
I want to focus on a small but important detail in the source material. It notes that milk and bile are not affected by this mechanism. Why highlight that?
It's important to keep the cholinergic system in perspective. While AC is a master key, it doesn't open every lock in the body. Milk and bile secretion are really complex processes governed more by hormonal stimuli, things like prolactin and cholecystokinin and other non-muscarinic nervous pathways. This exemption just shows the specific boundaries of PNS control.
Okay, now let's travel down the digestive tract, the GIT. What happens when we block M3 receptors there?
Well, AKE normally causes robust peristalsis, those smooth, wave-like contractions that move food along. When you block the M3 receptors, you dramatically decrease the tone and motility of the gut smooth muscle. Everything just slows down.
Which inevitably results in severe constipation.
Right, and then you have the urinary bladder. This effect alone can be life-threatening if it's ignored.
How so?
Well, the bladder functions using two main muscle groups controlled by the PNS. First, you have the detrusor muscle, the main wall of the bladder, which contracts to push urine out. Atropine relaxes it.
Okay.
Second, you have the sphincter muscle, the gate at the bottom, which controls outflow. Atropine tends to constrict it.
So you have a relaxed pusher and a tightened gate.
A perfect recipe for disaster, specifically urinary retention. The patient feels the need to urinate, but the bladder cannot effectively contract, and the outflow path is obstructed. This is why atropine and related drugs are an absolute no-go for men with prostate issues, as we'll discuss later.
And finally, the bronchi. We get a beneficial effect here, bronchodilation, but it comes with a dangerous trade-off.
For patients with airway constriction, like in asthma, relaxing the bronchial smooth muscle is a good thing. It opens the airway.
Yeah.
But because atropine is non-selective, it also dramatically reduces bronchial secretions.
Which leads to what?
It leads to the risk of forming thick, tenacious, hard mucus plugs in the airways, which can be extremely dangerous. This critical side effect is a major reason why atropine itself is rarely used for chronic lung conditions today and why we needed to develop specialists.
That makes the need for precision incredibly clear. But before we get to the specialists, we have to address the most dramatic and long-lasting effect of atropine, the eye. Now coming to our next slide. This one details atropine's vision, the effect on the eye.
This is the most famous historical use of belladonna, right? Dilating the pupils to enhance a woman's beauty.
That's precisely why it's called belladonna, beautiful lady. But the mechanism is just a dramatic pharmacological display. We see two simultaneous forms of paralysis in the eye.
What's the first one?
The first is passive mydriasis, or pupil dilation. The pupil size is controlled by two opposing muscles. Atropine paralyzes the constrictor pupillae muscle, the one that shrinks the pupil in bright light. With that brake released, the dilating muscles work unopposed, resulting in a passively enlarged pupil.
And the second effect, cycloplegia, is the one that really incapacitates a person for reading or any near tasks.
Cycloplegia is the loss of accommodation. This is paralysis of the ciliary muscle. That muscle is responsible for changing the lens shape, allowing your eye to adjust focus from a distant object to something close, like your phone.
So when it's paralyzed, when the ciliary muscle is paralyzed, your vision is fixed for distance, and anything near becomes severely blurred. You are effectively blind to anything within arm's reach.
The clinical bottom line here reveals why this is such a powerful, yet pretty limited drug for ophthalmology. The effect is just too long.
A duration of 7 to 10 days is remarkable. For a simple eye exam, that duration is just punitive. The patient loses their light reflex, the pupil won't react to light, so they have to wear dark glasses for a week.
And most importantly, the danger.
The biggest danger. The extreme dilation can precipitate acute glaucoma. If an individual has a narrow angle anatomy in their eye, that wide-open pupil can mechanically close the drainage pathway for eye fluid, causing intraocular pressure to spike catastrophically.
So atropine is immensely powerful. It's a critical emergency tool, but its non-selective nature hitting M1, M2, and M3 and crossing the BBB because of that tertiary amine structure results in this whole constellation of undesirable and potentially dangerous side effects.
The sledgehammer analogy holds true. You just can't use a sledgehammer for every delicate surgical task. You need specialized tools.
And that need for refinement brings us right to the next phase of this pharmacological journey. Now coming to our next slide.
Yes.
This one, slide 8, is titled A Powerful Tool, but Not a Precise One. It really summarizes the problem. Atropine's power is its undoing in chronic care. The non-selectivity leads to all those side effects we just listed, the dry mouth, urinary retention, blurred vision.
Right. If a patient needs long-term bronchodilation for COPD, they simply cannot tolerate the other effects atropine would impose on them day after day.
So what was the solution?
This is where science truly innovated. The solution wasn't to abandon the anticholinergic mechanism, but to develop atropine substitutes, a specialized team of drugs that could either target one receptor subtype, like M1 or M3, or, crucially, target one organ by manipulating the chemical structure to prevent systemic absorption. This is precision medicine in its purest form.
So they stopped trying to make one key fit every lock and started designing, well, lockpicks for specific doors.
Exactly. We used the knowledge of atropine's structure, that tertiary amine that goes everywhere, and designed molecules that couldn't go everywhere, creating local action right where we needed it.
Let's meet the team.
All right.
Now coming to our next slide, we begin with the eye specialists, mydriatics. Since a 7-day blur is completely unacceptable for a quick eye exam, the goal became shorter action.
Correct. The first step was a drug called homatropine. It's a bit less potent than atropine, but it cuts the duration down to a more manageable 1 to 3 days. Still long, but an improvement.
Then came cyclopentolate.
Cyclopentolate reduced that time even further, lasting around 24 hours. You can manage a day of blurred vision, but not a whole week.
But the undisputed winner for speed and convenience and the drug of choice for modern ophthalmology is tropicamide.
Tropicamide is the specialist designed for maximum speed. It is the fastest and shortest acting, lasting only about 6 hours. For a quick clinical need like checking the retina for diabetic changes or an optic nerve assessment, tropicamide ensures the patient has minimal downtime. It's a perfect demonstration that duration of effect can be optimized purely by chemical engineering.
Okay, moving on to the lung specialists for COPD and asthma. We already established that atropine is dangerous here because it causes those thick mucus plugs. The breakthrough was ipratropium and tiotropium bromide.
And the breakthrough lies entirely in their structure. They are quaternary compounds. Remember the tertiary amine atropine?
Lipophilic, crossed barriers.
Exactly. Quaternary amines carry a permanent fixed positive charge. That means they're highly water-soluble and virtually cannot cross the body's membranes or the blood-brain barrier.
So by administering them by inhalation, you're literally spraying the drug directly onto the lung tissue, the target organ. And because of that quaternary structure, the drug can't escape into the rest of the bloodstream to cause dry mouth or urinary retention.
That is the crucial insight. They selectively dilate the bronchi, achieving the anti-asthma effect without the systemic side effects, and critically, without significantly impairing mucus clearance. Tiotropium is particularly noteworthy because it's a longer-acting agent, providing 24-hour bronchodilation, which is essential for chronic management of diseases like COPD.
That transition from tertiary to quaternary structure is really the blueprint for safety and selectivity outside the CNS.
It absolutely is. Now, for the gut specialists, for peptic ulcer, we have pyrenzapine. This drug achieves selectivity not by location, but by focusing on a receptor subtype.
Pyrenzapine selectively blocks M1 receptors. Why does targeting M1 help with ulcers?
We established earlier that M1 receptors are involved in gastric acid secretion. So by blocking M1 specifically, pyrenzapine significantly reduces the production of stomach acid, thereby treating the ulcer.
But crucially,
It leaves the M2 receptors on the heart, and the majority of the M3 receptors controlling the salivary glands and bladder relatively untouched. This means far less dry mouth, less tachycardia, and fewer urinary issues. This represented a major step toward highly specific anti-ulcer therapy.
that explains the three main specialist approaches: shorter duration for the eye, structural manipulation for the lungs, and receptor selectivity for the gut.
You nailed it.
Okay, now coming to our next slide, we continue with the specialists, starting with general antispasmodics. These are the drugs used to calm involuntary muscle hyperactivity, often in the gut.
Correct. Dicyclomine, for instance, is a common agent used to calm intestinal colic, those severe abdominal cramps, and it's also frequently prescribed for dysmenorrhea or menstrual pain, which is caused by uterine smooth muscle spasms.
And we also have hyoscine butyl bromide.
Right, often used for acute, localized spasms, particularly GI and esophageal colic. These drugs provide generalized smooth muscle relaxation. They're fast-acting relief for an acute crisis, though they will carry the general anticholinergic side effects to some degree.
Okay, the next section is massive in terms of the patient population. The vesicose-selective specialist for the urinary bladder, treating overactive bladder and incontinence.
This is a huge field because the side effects of older drugs were just so poorly tolerated. The goal is to maximize the M3 blocking effect on the detrusor muscle to stop the bladder from contracting unnecessarily while minimizing the M3 block on the salivary glands.
You avoid that awful dry mouth.
Exactly. Early drugs included oxybutynin and flavoxate, which effectively relieve bladder spasm but often come with severe dry mouth.
And the dry mouth issue is often cited as the top reason patients just stop taking these drugs. So scientists had to solve the spit versus pee trade-off.
That led to agents like tolterodine. Tolterodine was a significant improvement because it was engineered to be more selective for the bladder than for the salivary glands. It offered a better therapeutic index, meaning patients could get control of their bladder with less of that annoying dry mouth.
And the latest evolution shows even greater precision with darafenacin and solifenacin.
These are really the pinnacle of M3 selectivity within this class. They are highly specific for the M3 receptor subtype, which controls bladder contraction, ensuring maximal efficacy for urinary incontinence. They're also long-acting, often only requiring a single dose per day, which simplifies the patient's regimen dramatically. The whole journey from atropine to solifenacin perfectly illustrates that quest for specialized precision.
This theme of structure driving function is so powerful. We've used the quaternary structure to keep drugs out of the bloodstream for the lungs, and now we need to look at drugs specifically designed to cross into the brain.
Now coming to our final specialist slide, which covers two critical areas. First, the central nervous system specialists for Parkinsonism.
Right. Since Parkinson's tremor involves an imbalance in the brain, these drugs must be able to cross the BBB. That means they must be tertiary amines.
Absolutely. The chemical identity is non-negotiable here. Drugs like benzhexyl, also called trihexyphenidyl, benztropine, biparidine, and procyclidine are all tertiary amines. They're designed to enter the brain and help restore the balance between the inhibitory cholinergic pathways and the stimulating dopaminergic pathways, thus controlling the tremor and rigidity that define the disease.
So they succeed because they embrace the very CNS activity that atropine causes as a side effect.
Precisely. The side effect becomes the therapeutic target. Now let's look at the complete opposite scenario. The pre-anesthetic medication specialist. This is glycopyrrolate.
This drug is critical for surgery prep, and we noted it is a quaternary compound. That means it does not cross the blood-brain barrier.
And that is its greatest strength in the operating theater. When a patient is under general anesthesia, you want control, calm, and a dry, clear airway. You absolutely do not want CNS side effects like agitation, confusion, or delirium, which a tertiary amine like atropine would risk causing.
So glycopyrrolate provides the peripheral safety without the central risk. What are the two vital actions it performs during surgery?
First, it prevents life-threatening vagal bradycardia. Surgical maneuvers can sometimes simulate the vagus nerve, causing the heart to slow dangerously. Glycopyrrolate blocks the M2 receptors in the heart, ensuring the heart rate stays steady.
And second,
And critically for airway management, it drastically reduces respiratory and salivary secretions. This ensures the anesthetist has a clear, dry field for intubation and throughout the procedure, minimizing the risk of aspiration. Glycopyrrolate is the perfect quaternary solution for the periphery.
the distinction between the tertiary amines for the brain and the quaternary amines for the periphery is truly the organizing principle of this entire drug class.
Without a doubt.
Okay, we've built the team. Now it's time to put them on assignment. Now coming to our next slide.
This slide synthesizes everything we've learned, matching the problem to the specialist. This is the application phase of our deep dive.
Mission 1. We need a quick result for an ophthalmic exam, the agent.
Has to be tropicamide. Shortest duration, highest convenience.
Mission 2. Chronic management of COPD.
Ipratropium or tiotropium. Inhaled, quaternary structure, maximum local safety.
Mission 3. Airway management and cardiac stability during pre-surgery prep.
Glycopyrrolate. Quaternary peripheral only action, no question.
Mission 4. Treating overactive bladder.
Tolterodine or sulfasenacin. The M3 selective agents that minimize that awful dry mouth side effect.
Mission 5. Controlling Parkinsonism tremor.
Benzhexol or benztropine. The tertiary amines that must cross the BBB to work centrally.
And the final two critical missions still rely on the original non-selective master key, atropine. Why is that?
Because in an emergency, you don't have time for selectivity. Mission 6, antidote for poisoning, and Mission 7, treat severe bradycardia, require maximum immediate systemic muscarinic block. Only non-selective atropine provides that essential systemic coverage instantly.
This slide beautifully illustrates that the old drug and the new specialists each have their own indispensable place.
Now coming to our next slide on safety. Even the specialists, particularly the vesicoselective ones, carry risks. We must always be aware of the potential collateral damage, side effects, and contraindications.
We have the classic, easy-to-remember mnemonic for anticholinergic side effects. Every medical professional knows this one. Let's remind our listener.
You must remember this pattern of system shutdowns. Can't see, can't pee, can't spit, can't...
Bloop. Let's link those back to the specific receptor and the anatomical failure.
Okay, can't see is the blurred vision from cycloplegia, paralysis of the ciliary muscle. That's an M3 receptor effect. Can't pee is urinary retention due to the detrusor muscle relaxing and the sphincter tightening, also M3. Can't spit is dry mouth, the universal consequence of blocked M3 salivary receptors. And can't poop is constipation due to decreased gastrointestinal motility, again, M3.
Okay, now on to the absolute, critical, do not use these scenarios, the contraindications. These are non-negotiable safety rules.
First, glaucoma, specifically the narrow angle type. If you give a patient with narrow angle glaucoma and an anticholinergic, the resulting massive pupillary dilation can physically obstruct the outflow drainage system of the eye. This causes the fluid pressure to spike rapidly and violently,
leading to acute, painful glaucoma and potential permanent blindness.
It's an immediate and catastrophic risk.
And the second major contraindication relates back to the can't pee effect, which is particularly risky in the aging population.
That is benign prostatic hypertrophy, BPH. BPH means the prostate gland is already enlarged, often in elderly men, and is partially constricting the urethra, making urination difficult.
So if you add an anticholinergic drug,
which relaxes the bladder's engine and tightens the bladder's exit gate, you guarantee severe or total urinary blockage. This can lead to hydronephrosis and requires emergency catheterization, pain, and hospitalization. For any patient with known BPH, these drugs have to be approached with extreme caution.
Okay, now coming to the next slide, we have a scenario where all these side effects coalesce into one terrifying clinical picture. Red alert, atropine poisoning. This is the classic toxidrome. We have to detail the famous rhyme associated with this state.
Yes, this mnemonic perfectly captures the high-dose, systemic, central, and peripheral effects of uncontrolled anticholinergic activity.
First, hot as a hair.
This is hyperthermia, high body temperature. It happens because the M3 receptors controlling sweat glands are completely blocked. The body cannot sweat, so it can cool itself efficiently.
Next, blind as a bat.
This refers to the fixed, dilated pupils mydriasis and the severely blurred vision from cycloplegia. The patient is temporarily functionally blind.
Dry as a bone.
All secretions, saliva, tears, sweat are gone. The mouth and skin are severely desiccated.
Grad as a beet.
The skin is flushed, often due to massive peripheral vasodilation, as the body desperately tries to radiate heat away since it can't sweat.
And the definitive CNS effect, mad as a hatter.
This confirms the presence of the tertiary amine atropine crossing the BBB. The patient is confused, delirious, possibly paranoid, and experiencing vivid hallucinations. It's a profound central nervous system disruption.
So when a patient presents with this complete clinical picture, what is the specific life-saving antidote?
The antidote is physostigmine, administered slowly intravenously, about 1 to 4 milligrams. Physostigmine is an acetylcholinesterase inhibitor. That means it prevents the enzyme that normally breaks down acetylcholine from doing its job.
So instead of trying to clear the atropine, we are suddenly flooding the system with the natural key, ADIS, to overwhelm the blocker.
Exactly. We dramatically increase the concentration of the natural key, forcing it to competitively displace the atropine molecules from the receptor locks. This rapidly reverses the peripheral symptoms.
But the key distinction for the antidote relates back to our structural theme. Why is physostigmine, and not just any cholinesterase inhibitor, the correct antidote here?
Because physostigmine is itself a tertiary amine. Just like atropine, it is fast-soluble and can cross the blood-brain barrier. You must reverse the central effects, the mad as a hatter state, to save the patient. A quaternary antidote would fix the dry mouth and heart rate, but the patient would remain severely delirious and risk self-harm. Physostigmine tackles both the periphery and the brain simultaneously.
That's a critical point. Okay, now coming to our next slide. To truly master this material, we need to focus on some advanced clinical differentiations. Slide 15 helps us master the details with key comparisons and learning hacks. Let's start with the advanced comparison of mydriasis in the eye.
This is crucial for emergency medicine and ophthalmology. Is the patient's dilated pupil due to an anticholinergic like atropine or a sympathomimetic like phenylephrine? The clinical presentation is totally different.
Okay, let's compare the mechanism of mydriasis.
Atropine causes passive mydriasis. It paralyzes the constrictor muscle. Phenylephrine causes active mydriasis. It actively stimulates the dilator muscle.
And how does that affect accommodation, the ability to focus?
Atropine paralyzes the ciliary muscle, causing cycloplegia, that loss of focus. Phenylephrine only acts on the iris muscles, so accommodation is unaffected.
And the crucial diagnostic test, the light reflex.
Since atropine paralyzes the constrictor muscle, the pupil will not react to light. The reflex is lost. With phenylephrine, the constrictor is functional, so the light reflex is still present, though sometimes a bit sluggish.
And finally, intraocular pressure, or IOP.
Atropine carries that high risk of causing IOP to rise, which can lead to glaucoma. Phenylephrine, on the other hand, often causes IOP to be reduced. These 4 comparison points are the foundation for diagnosing pupillary causes.
Okay, let's wrap this section up with the learning hacks, the mnemonics we need to organize those long lists of specialists. Let's start with the drugs whose quaternary structure guarantees peripheral action.
Right, remember, quaternary means they stay peripheral because they can't cross barriers. The main ones are glycopyrrolate, ipratropium, piotropium, and clydinium. Our mnemonic for these is simple and powerful. Guys in the flubs stay peripheral.
GITC. Glycopyrrolate, ipratropium, tiotropium, clydinium. That immediately links their structure to their safe route of action. I like that.
And our second key group is the vasicoselective drugs, the specialists for the urinary bladder. These are fluvoxate, oxybutynin, tolterodine, sulfonacin, and darafenacin.
And the logical mnemonic that links them to their primary patient population?
Friends of the senior department.
FOTSD. Fluvoxate, oxybutynin, tolterodine, sulfonacin, darafenacin. That ensures that when you see that drug list, you immediately recall their intended application in senior care for incontinence and overactive bladder.
Exactly.
These tricks really do help cut through the density of the drug names. Now coming to our final source, slide 16 brings everything together with a knowledge check. Applying your expertise. Let's tackle these 3 critical clinical scenarios.
Okay, these questions test not just rote memory, but synthesis of the structural and functional principles we've been discussing.
Q1. A 75-year-old man with BPH needs a drug for COPD. Why is inhaled tiotropium a much safer choice than oral atropine?
The answer is entirely rooted in safety and structure. Tiotropium is a quaternary amine, ensuring it's poorly absorbed systemically and it's delivered locally to the lungs. This vastly minimizes the risk of causing systemic urinary retention, the greatest danger for a patient with BPH.
Whereas oral atropine.
Oral atropine, a tertiary amine, would be systemically absorbed, and it would almost certainly precipitate a life-threatening blockage in that man.
Okay, Q2. A patient arrives in the ER after an organophosphate insecticide exposure. They have excessive salivation and bradycardia. What is the life-saving antidote?
This is a classic case of acetylcholine excess. We need an immediate, non-selective systemic block. The antidote must be atropine. It blocks the overwhelming muscarinic effects across the heart and glands, restoring vital functions.
And finally, Q3. Your patient complains of severe dry mouth after starting a new medication for overactive bladder. Which drug could be a better alternative due to its higher selectivity for the bladder over salivary glands?
This is the problem of M3 selectivity. We are looking for the agent designed to improve that spit versus P balance. The key drugs here would be tolterodine, or the modern M3 selectin agents like solifenacin or darafenacin, which offer better adherence and quality of life by reducing that peripheral M3 block on the salivary glands.
That brings us to the end of our exploration. What stands out to you as the ultimate takeaway from this deep dive?
I think it's the realization of the pharmacological evolution. We started with atropine, this powerful but crude master key that hit every single lock, resulting in those terrifying toxic effects and the predictable widespread side effects like dry mouth and urinary retention.
And the scientific response was just brilliant. Instead of accepting the side effects, they engineered around them. They realized the critical role of chemical structure, the difference between a lipophilic tertiary amine that goes to the brain, like benztropine, and a charged quaternary amine that stays peripheral, like glycopyrrolate or tiotropium.
Yes, and they developed receptor selectivity to minimize collateral damage, giving us M1 blockers for the stomach and M3 blockers for the bladder.
So understanding that key lock mechanism and the tertiary quaternary structure is the absolute master key to understanding this entire crucial drug class.
It truly is.
So let's leave you with one final thought based on this quest for specialization. We have successfully developed highly selective M1 blockers and M3 blockers. We know that the M2 receptors are primarily located in the heart and function as the body's natural brake, slowing the heart rate via AHTA.
So what if future pharmaceutical breakthroughs allow us to synthesize a drug that is a pure, ultra-selective M2 receptor antagonist, a drug that only and precisely blocks that cardiac brake? What new therapeutic strategies could this open up in cardiology?
We currently rely on the non-selective power of atropine for acute bradycardia. Imagine a highly targeted drug that could permanently modulate heart rhythm disorders by safely removing that M2 brake.
Without causing cycloplegia, without causing dry mouth, or any of the CNS effects.
A truly fascinating possibility for the future of precision heart medicine.
Skeletal muscle relaxants.
And this is such a critical topic. I mean, it touches everything from the most high-stakes moments in an operating room, like getting a breathing tube in, all the way to managing the daily chronic struggle of conditions like multiple sclerosis.
Absolutely. And you, our listeners, send us some fantastic source material. We've got 15 slides here, clearly designed for someone studying advanced pharmacology. So our mission today is to go beyond just listing drugs. We want you to understand the why.
The clinical rationale, right. Why does a doctor choose this drug and not that one for this specific patient? It's all about context.
Exactly. We're starting from the absolute basics, from the central command of the nervous system, and we're going all the way up to the most advanced clinical strategies.
And that first slide really sets the stage perfectly, doesn't it? Skeletal muscle relaxants, a pharmacological masterclass. From central command to muscle contraction. It tells you right there. We have to understand how the signal works before we can figure out how to block it.
Okay, let's unpack this. Now, coming to the next slide, we start with the absolute basics. Before we can even think about relaxing a muscle, We have to understand, how do we contract it?
Right. You have to know the normal before you can understand the abnormal, or in this case, the intervention.
And the analogy here is perfect. Think of it like a military command, an order that starts at headquarters and has to get all the way down to the frontline troops with a few key steps in between.
And every single drug we're going to talk about today is designed to interrupt one of these steps. So if you can get this sequence down, everything else will it'll click into place.
All right, let's break it down. Step 1, command issued. This is the general in headquarters, the central nervous system, the spinal cord, deciding to make a move. An electrical impulse is sent out.
And it travels down this long wire, the motor neuron axon. It's a very fast, very specific electrical signal. But that nerve doesn't actually touch the muscle.
Right, there's a tiny gap.
A microscopic gap, the neuromuscular junction, or NMJ. And since electricity can't jump that gap, you need a messenger, a chemical messenger.
Which brings us to step 2, messenger released. The electrical impulse hits the end of the line, the axon terminal, and triggers the release of our key chemical courier.
Acetylcholine, or ASHIC for short. These little sacs just burst open and flood that gap, the synaptic cleft, with millions of these HEM molecules. The message is now officially sent.
Okay, so the message is out there. Step 3 is message received. These AHE molecules drift across that tiny gap, and they had to dock onto very specific receptors on the muscle side.
The Nicotinic Nn receptors. And I want to pause here for a second because this junction, the NMJ, is so important. This is the bottleneck. This is where most of our heavy-hitting surgical drugs do their work. It's the point of maximum leverage.
So once that key, the HE, fits into the NM receptor, what happens next?
Well, then we switch from chemical back to electrical. And this is step 4, action. When H binds, the receptor channel flies open and allows a huge rush of positively charged sodium ions into the muscle cell.
And that sudden change in charge is called?
Depolarization. That's the key. This creates a new electrical wave, a muscle action potential, or MAP, and that is the final, undeniable command for the muscle fiber to contract. The troops are moving.
Okay, but if that was it, we'd be stuck. We'd contract and just stay contracted.
Exactly. So you need a cleanup crew, and you need it fast. That's step 5, cleanup. There's an enzyme waiting right there in the synaptic cleft called cholinesterase.
The cleanup crew. I like that.
It's perfect, right? Its only job is to find and destroy acetylcholine, chopping it up almost instantly. This stops the signal, allows the muscle to repolarize, and gets it ready for the next command. It's an incredibly elegant system.
You said the NMJ is the crucial bottleneck. Why focus there instead of, say, just quieting the signal way up in the spinal cord?
Specificity. If you act up in the brain or spinal cord, you're going to affect everything. You'll make the patient drowsy, confused. You're using a sledgehammer. But the NMJ lets you use a scalpel. You can target just the communication between nerve and muscle, achieving profound paralysis for surgery without knocking the patient out. They remain conscious, which is why you always need anesthesia, too.
That makes perfect sense. And it sets us up beautifully for the next part of our discussion. Now, coming to the next slide, it's all about strategy. If we know the chain of command, we know the 3 key places we can intervene to cause relaxation.
Yep, every single muscle relaxant fits into one of these 3 buckets based on where it acts.
Okay, approach number 1, we go right to the top, the central command, the CNS.
These drugs act in the brain and spinal cord. The goal here is basically to tell the general to just issue fewer orders, calm things down at the source.
Then there's approach 2, the junction. This is acting peripherally, right at the NMJ.
Right. This is the communication jammer on the front line. You're not telling the general to be quiet. You're just stopping the message from ever being received by the troops. This is where the big surgical drugs live.
And finally, approach 3, the muscle fiber itself, a direct-acting approach.
This is a really unique one. You're bypassing the general, you're bypassing the communication system, and you're going right to the tank and disabling its engine. The order might get through, but the muscle physically can't respond.
Central, junction, and direct. That's the whole map.
That's the whole map.
All right, let's start at headquarters. Now, coming to the next slide, we're diving into approach 1, calming central command. Clinically, these are known as the spasmolytics.
Right, and the name tells you what they do. They fight spasm and spasticity. This isn't about surgical paralysis. This is about treating chronic conditions like cerebral palsy or MS, where the muscles are involuntarily tight all the time.
Or even something acute, like a really bad back strain.
Exactly. The problem originates in the CNS. The signals are overactive, so the drugs have to work in the CNS.
And the mechanism is described here as turning down the volume. How do they do that?
Well, they tip the balance in the nervous system. They either boost the stop signals, the main inhibitory one being GABA, or they reduce the go signals, the excitatory ones like glutamate.
Yeah.
Either way, you're making the motor pathways less twitchy, less overexcited.
So their main use is for things like multiple sclerosis, spinal cord injuries, or even just acute trauma causing a muscle to lock up.
Precisely. But here's the crucial trade-off, and it's the defining characteristic of this entire class of drugs.
The side effects.
The side effects. Because they act on the central nervous system to turn down the volume on motor signals, they inevitably turn down the volume on other things too. So sedation and drowsiness are incredibly common. It's almost unavoidable.
So the patient gets relief from the spasticity, but they might feel groggy or less alert.
It's a constant balancing act.
Okay, now let's meet the specific troops in the central command roster. Coming to the next slide, we've got a whole list here of the key spasmolytics.
And we really need to go through these one by one because they each have a slightly different flavor.
Let's start with baclofen. This is a big one.
It is. Its mechanism is very specific. It's a GABA B agonist, so it mimics GABA, the body's main off switch, specifically at the B-type receptor. This makes it harder for those overactive nerve signals in the spinal cord to fire.
And it's used for spasticity from spinal lesions, amascript. Pretty heavy-duty conditions.
Very much so. It's a workhorse. But the side effects can be significant drowsiness, of course, but also confusion, ataxia, which is a kind of wobbliness or a lack of coordination.
Next on the list, a very famous name, diazepam, one of the benzodiazepines.
Right, like Valium. Now, diazepam also enhances GABA, but it works on the GABA A receptor, not GABA B. It basically holds the channel open longer, letting more chloride ions in, which calms the neuron down.
And its uses include tetanus. That seems extreme.
Tetanus is the ultimate state of muscle spasm. The toxin blocks all inhibitory signals. So a drug like diazepam that powerfully boosts the remaining inhibitory signals is a lifesaver. But for everyday use, the sedation is really strong, and there's a risk of dependence.
Moving on to tizanidine. This one's different. It's not a GABA drug.
Nope. This one is a central alpha-2 agonist. Think of alpha-2 receptors as a brake pedal on the nerve ending. When you stimulate them, they release fewer excitatory neurotransmitters. It's another way to turn down the volume just through a different pathway.
And why might a doctor choose this over baclofen?
The big advantage can be less sedation. You can often get good muscle relaxation at a dose that lets the patient stay a bit more functional and alert. But you have to watch for other side effects, like dry mouth and sometimes low blood pressure.
Then we have a pair, chlorzoxazone and methylcarbamol.
These are your classic drugs for acute injuries. A bad fall, whiplash, a pulled muscle in your back. They act on the spinal interneurons to break that local pain spasm pain cycle.
And the main side effect is, let me guess.
Drowsiness, of course. They're meant for short-term use while the injury heals.
Okay, two more. Carisprodols.
Yeah. Its mechanism is listed as not fully known, which always makes us a bit nervous in pharmacology. It definitely causes CNS depression, but it also has a metabolite with a high potential for abuse, so it's prescribed much more cautiously these days.
And finally, thiocalcicicide.
This one's a bit of an oddball mechanistically, but clinically it's used for sprains and trauma. And again, you see drowsiness, but also sometimes diarrhea or rashes.
That's a lot of names to keep straight. The source material offers a mnemonic to help out.
It's a good one. For the common spasmolytics, just remember, bad back things. Calm down.
Let's break that down.
So the first B is for baclofen.
Right.
The second B is for benzodiazepines like diazepam. The T is for tizanidine. And the C and D can stand for carisoprodol, chlorzoxazone, and diazepam. It helps group the major players together.
And the big takeaway for this whole section is that the central mechanism is directly linked to the most common side effect. If it calms the brain, it's going to cause
drowsiness. Every time. It's the price of admission for this class of drugs.
Okay, so we are leaving the general's office now and moving to the front line. Now coming to the next slide, we're on to approach 2, intervening at the junction, the NMJ.
This is a massive shift in thinking. We are now in the world of anesthesia. These are the neuromuscular blockers. They work peripherally.
And this is probably the single most important point for you to remember. These drugs cause profound total muscle paralysis, but they do not affect the CNS.
At all. A patient given one of these drugs alone would be completely awake, able to feel everything, but utterly unable to move. A terrifying thought.
Which is why they are always given with a general anesthetic. Their job is paralysis, not sedation or pain relief.
Right. And because they paralyze everything, including the diaphragm, the patient can't breathe. So you absolutely need mechanical ventilation life support anytime you use them.
The slide divides them to two major types based on how they interact with that nicotinic receptor.
Exactly. You have the competitors and you have the imposters.
Okay, explain. The first type is competitive or non-depolarizing blockers.
These are the antagonists. They are like a piece of gum in the keyhole. They just sit on the receptor, physically blocking acetylcholine from getting in. No ACE binding means no signal, which means
Flaccid paralysis, a limp muscle.
pure and simple.
Yeah.
The second type is the depolarizing blocker.
The imposter.
The imposter, there's really only one we use. Succinylcholine. It's an agonist, so it actually mimics acetylcholine. It fits in the lock and turns it, but then it gets stuck.
A key that breaks off in the lock.
Perfect analogy. It holds the channel open, overstimulating it. This causes a brief, chaotic muscle twitch, a fasciculation, which is then followed by paralysis because the whole system just gets overloaded and shuts down.
So the end result is the same paralysis, but the way they get there is completely different. One just blocks, the other overstimulates to the point of failure.
And that initial twitch is a key clinical sign that tells you exactly which type of drug was used.
Let's focus on that fast-acting imposter. Now, coming to the next slide, we're dedicating a whole section to it. The imposter, succinylcholine.
And for good reason. It's one of the most useful and most dangerous drugs in medicine. Structurally, it literally looks like two acetylcholine molecules stuck together, which is why it acts like one.
The slide breaks its action down into two phases. Let's start with phase I block.
So succinylcholine binds to the NM receptors and forces them open. You get that initial disorganized muscle twitching all over the body. Those are the fasciculations. But because the drug doesn't let go, the muscle membrane can't repolarize. It can't reset itself for the next signal. And that leads to a profound flaccid paralysis.
And what about phase II block?
This happens with continued exposure, which is less common because we usually only use it for a few minutes. But if you did, the receptor itself becomes desensitized. It just gives up. And interestingly, at this stage, the block starts to look a lot more like the non-depolarizing kind.
What gives it its edge in an emergency is its speed. It works incredibly fast.
Super fast onset and a super short duration, usually 3 to 8 minutes. And that's because it's chewed up very quickly in the blood by an enzyme called pseudocholinesterase.
Not the same as the cholinesterase at the junction.
Correct. A different enzyme that lives in the plasma. This rapid breakdown is why it's the #1 choice for things like endotracheal intubation, where an ER doctor needs to get a breathing tube in right now. You get profound paralysis for about 60 seconds, and then it wears off.
With great power comes great responsibility. Now, coming to the next slide, we have to cover the severe risks. This is the handle with care section for succinylcholine.
And these risks are not trivial. They are life-threatening. The first is hyperkalia, a massive spike in potassium.
Why does that happen?
Those initial fasciculations, the muscle twitches, they cause potassium, which is normally stored inside muscle cells, to leak out into the bloodstream. In a healthy person, it's not a big deal.
But in someone with, say, a major burn or a crush injury,
It can be fatal. Their muscle cells are already damaged and leaky. Giving them succinylcholine can cause a potassium surge so high it stops the heart. It's absolutely contraindicated in those patients.
the second risk is maybe the most feared complication in all of anesthesia.
Malignant hyperthermia, or MH. It's a rare genetic condition. And when a susceptible patient gets succinylcholine along with an inhaled anesthetic like halothane, it can trigger a metabolic explosion.
What does that look like?
Uncontrolled calcium release inside the muscles. This leads to extreme muscle rigidity, a dangerously high fever, a core temperature climbing minute by minute, and a massive metabolic crisis. It's a true emergency.
And there's a critical drug alert here. There's one specific antidote.
Yes, you must immediately give intravenous dantrolene. It is the only thing that can stop this process. Every operating room is required to have an MH cart with dantrolene ready to go.
A third risk is called prolonged sux apnea. What's that?
Remember that plasma enzyme, pseudocholinesterase, that breaks the drug down? Well, some people are born with a genetic deficiency. They don't have enough of it.
So the drug doesn't wear off.
It doesn't. Instead of being paralyzed for 5 minutes, they're paralyzed for 5 hours. They have to be kept on a ventilator until the drug finally clears, or until they're given fresh frozen plasma, which contains the enzyme.
Wow. And there are other effects, too, Muscle pain the next day for the fasciculations, increased eye pressure, stomach pressure.
It's a powerful but dirty drug. You use it when you need speed above all else, and you have to be prepared for the consequences.
Okay, let's move away from the imposter and back to the main competitive class. Now coming to the next slide. The competitors, non-depolarizing blockers.
Right. These are the workhorses for most planned surgeries. They are competitive antagonists. They block the receptor, causing a clean, flaccid paralysis without any of the initial twitching.
And again, to be clear, they do not affect consciousness or pain. Anesthesia is a must.
Absolutely. And the slide points out a great little hack for identifying them, the CUR clue.
Right. If the drug name has curonium or tanycurium in it, it's a non-depolarizing blocker.
It's a nod to curare, the original arrow poison from which the prototype, D-tubocurarine, was derived. Pancuronium, rocuronium, atracurium. They all follow the rule.
The slide also talks about the order of paralysis. It's not an all-at-once event.
No, it's very predictable. The small, fast-moving muscles go first. So the eyes, then the face and neck, then the limbs, then the trunk.
And the last to go.
The respiratory muscles, the diaphragm, and the intercostals. This is a critical safety feature. And recovery happens in the exact reverse order. The diaphragm comes back first, which is what the anesthesiologist is watching for before they take the breathing tube out.
And unlike acetylcholine, these are reversible.
Yes, you can overcome the block by flooding the synapse with more acetylcholine using drugs kind of anticholinesterase like neostigmine. It's a huge advantage.
Okay, now coming to the next slide, we get into the details. This is the drug table, choosing the right agent for the job. This is where we see why a doctor picks one curonium over another.
It all comes down to two things. How long is the surgery? And does the patient have healthy organs, specifically liver and kidneys?
Let's start with the long-acting agents. The prototype, D-tubocurarine.
The original, but almost never used today. And the reason is one big side effect. Massive histamine release.
Which causes what?
Hypotension, a big drop in blood pressure, and bronchospasm. Very dangerous. So we moved on to things like pancuronium.
Pancuronium is long-acting, but doesn't release histamine.
Correct. But it has its own quirk. It has a vagolytic effect, which means it can cause the heart rate to go up, or tachycardia. Still useful for very long cases, though.
Most of the action today is in the intermediate acting group, like vecuronium.
Vecuronium is a really popular, clean drug. Very few cardiovascular effects, no histamine release. It's reliable and predictable.
And then there's its cousin, rocuronium. This one gets a star.
It does. Rocuronium's claim to fame is its rapid onset. It's the fastest of all the non-depolarizing blockers, almost as fast as succinylcholine.
So it can be used for intubation, but without the risks of succus.
Exactly. And it has another massive advantage. It's the only one that can be specifically reversed by a drug called sugammadex, which we'll talk more about later. This makes it incredibly safe and versatile.
Now for the special cases, atracurium and cistracurium.
These are brilliant. Their unique feature is how they're eliminated. They undergo spontaneous degradation in the plasma, a process called Hoffman degradation. It doesn't require the liver or the kidneys at all.
So they're perfect for a patient in renal failure or liver failure.
The absolute best choice. Now, atracurium, the original, has a downside. It causes some histamine release.
Which is why we now have cistracurium.
Exactly. It's an isomer of atracurium. It also uses Hoffman degradation, but it does not cause histamine release. It's the safer, cleaner version for these critically ill patients.
And finally, a short-acting one, mivacurium.
Short duration, about 15-20 minutes. But, like some of the older drugs, it also causes histamine release, which has limited its use.
All right, let's move on to our final category. Let's look at that dedicated engine disabler. Now, coming to the next slide, we have approach 3, acting directly within the muscle. The drug here is dantrolene.
Dantrolene is totally unique. It bypasses the nerve and the junction completely. It works right inside the muscle cell.
How does it do that?
Well, for a muscle to contract, calcium has to be released from an internal storage tank called the sarcoplasmic reticulum. That release happens through a channel called the ryanodine receptor, or YR1. Dantrolene physically blocks that channel.
So no calcium release, no contraction, it's locking the fuel tank.
Precisely. The command might be sent, the message might be delivered, but if there's no fuel, the engine can't turn over.
And this mechanism perfectly explains its two primary uses. The first one we already mentioned.
As the life-saving antidote for malignant hyperthermia, MH is a disease of runaway calcium release, so a drug that directly blocks calcium release is the perfect fix.
And its second use.
It can be used orally to treat chronic spasticity in conditions like MS or cerebral palsy. It's another tool in the toolkit for that.
And the adverse effects would be what you'd expect. Generalized muscle weakness, drowsiness, and because it's metabolized in the liver, you have to watch out for hepatotoxicity with long-term use.
Exactly.
Okay, we finish our classifications with a special agent you might know from the cosmetic world. Now coming to the next slide.
Yes. The special agent, botulinum toxin or Botox.
Most people think of wrinkles, but it's a potent therapeutic drug. And its mechanism is, again, totally different. It works presynaptically.
This is key. It works before the message is even sent. The toxin gets inside the nerve ending and acts like a tiny pair of scissors. It finds and cuts up the proteins that are required for the acetylcholine vesicles to fuse with the membrane and release their contents.
It destroys proteins with names like synaptobrevin, syntaxin, and SNP25.
Right. It's preventing the messenger from ever leaving the post office. No ACE release means no signal to the muscle.
And the result is a very localized, very long-lasting paralysis.
Which is perfect for its uses. Therapeutically, you can inject it into a specific spastic muscle in a cerebral palsy patient or to treat dystonia. And cosmetically, you inject it into the muscles of the face to stop them from contracting and forming wrinkles.
The adverse effects are mostly related to where you injected pain or maybe the paralysis spreading a bit to a neighboring muscle.
Correct. It's a highly targeted therapy.
Okay, we've covered the mechanisms. Now let's get practical. How do these drugs interact and how do we turn them off? Now coming to the next slide, we're looking at a clinical toolkit, interactions and reversal.
This is mission-critical information for anyone in an operating room. First, what makes the block from non-depolarizing agents stronger?
Certain antibiotics, like aminoglycosides.
Yes, they can inhibit the release of ACE from the nerve so the blocker has less competition. Also, the inhaled anesthetics themselves, isoflurane, halothane, they all enhance the block.
And also diuretics. Why is that?
Because diuretics can cause hypokalemia, low potassium, and low potassium makes the muscle membrane more sensitive to the blocking agent. It dramatically potentiates the effect.
Okay, now for the most important part, reversing the blockade. How do we wake the muscles back up?
The classic way is with anticholinesterases like neostigmine.
The drugs that inhibit the cleanup crew.
Exactly. You stop the enzyme that breaks down HAA levels in the synapse skyrocket, and they eventually build up enough to outcompete the blocker and kick it off the receptor.
But there's a crucial caveat here, a big warning.
A huge one. When you flood the body with AKA, you don't just stimulate the nicotinic receptors at the muscle. You also stimulate muscarinic receptors everywhere else.
And what does that do?
On the heart, it can cause severe bradycardia, a dangerously slow heart rate. It's a major risk.
So you have to co-administer it with something else.
Always. You must give it with an antimuscarinic agent like atropine. Atropine blocks the unwanted effects on the heart, keeping the patient safe while neostigmine reverses the paralysis. It's a mandatory combination.
But now there's a modern, more elegant solution. Sugammadex.
This drug is a game changer. It doesn't mess with enzymes or neurotransmitters at all. It's a large molecule that works like a molecular sponge. It directly finds, encapsulates, and inactivates rocuronium and vecuronium molecules right in the bloodstream.
It just traps the drug?
It literally traps it in a cage and allows the body to excrete it. It provides a much faster, more complete, and safer reversal for those specific agents. It's a major advance.
Now, coming to the next slide for a high-level summary table of everything we just covered. This is the skeletal muscle relaxants at a glance slide.
This really ties it all together, focusing on the mechanism and that key question of CNS effects.
First, centrally acting. They work in the CNS by boosting GABA or hitting alpha-2 receptors, used for spasticity. Do they have a CNS effect?
Yes, big time. Sedation is the hallmark.
Second, the depolarizing blotter, acetylcholine. It's an agonist of the NMJ, used for rapid intubation. CNS effect.
No, the patient is paralyzed but awake.
Third, non-depolarizing blockers, the cheroniums. They're antagonists of the NMJ, used for surgical paralysis. CNS effect.
No, again, purely peripheral.
Fourth, the directly acting drug, dantrolene. Blocks RI1 calcium channels in the muscle, used for MH and spasticity. CNS effect.
Yes, drowsiness is a known side effect of oral use.
And fifth, the AC release inhibitor, Botox. Works presynaptically, used for local spasticity in cosmetics. CNS effect.
No, it's a local peripheral action.
That table is crystal clear. The dividing line is really between the drugs for chronic conditions that make you drowsy and the surgical drugs that paralyze you but leave your brain untouched.
It's the most important distinction to make.
To solidify this knowledge, let's apply your understanding to the real world. Now, coming to the next slide, we have 3 clinical scenarios.
Okay, let's do it. Scenario 1. A patient in surgery with halothane and a muscle relaxant suddenly develops a high fever, a fast heart rate, and severe muscle rigidity. What's happening and what do you do?
Okay, the combination of an inhaled anesthetic and a relaxant, plus that classic triad of fever, tachycardia, and rigidity that just screams malignant hyperthermia.
Absolutely textbook. The trigger was likely succinylcholine plus the halothane. So what's the antidote?
It has to be intravenous dantrolene, immediately. You have to block that runaway calcium release or the patient won't survive.
Correct. Okay, scenario 2. A patient with end-stage renal failure needs a long surgery. Which non-depolarizing blocker is the safest choice and why?
So kidneys are out of the picture for elimination. You need a drug that doesn't rely on them, that points directly to the drugs that use Hoffman degradation.
Right, so your choices are atracurium or cisatracurium. Which one is better?
It has to be cisatracurium.
Right.
Because while both are cleared independently of the kidneys, cisatracurium doesn't cause that risky histamine release, which could cause hypotension in an already fragile patient.
Perfect clinical reasoning. Last one, scenario 3. Neostigmine is given to reverse a block. The patient starts breathing, but their heart rate plummets to 35. What was forgotten?
They forgot the buddy drug. They gave the neostigmine to boost acetylcholine, but they forgot to give atropine to block the muscarinic effects of all that extra AC on the heart.
And that's what caused the life-threatening bradycardia. It highlights that reversal with anticholinesteroses is always a 2-drug procedure.
Great scenarios. Let's wrap up with a few most important questions to really synthesize this for you. Q1. Why is succinylcholine almost never used outside of a hospital?
Because the risks, hyperkalemia and malignant hyperthermia, are so severe that you need an entire medical team and rescue equipment, including a ventilator and dantrolene, on standby. The risk profile is just too high for any other setting.
Q2. What's the single biggest difference between a spasmolytic like baclofen and an NMJ blocker like rocuronium?
The effect on the brain. Baclofen works centrally and causes CNS depression drowsiness. Rocuronium works peripherally, causing paralysis while leaving the patient fully conscious. One is for chronic conditions, the other is for surgery.
In Q3, what non-depolarizing blocker is the fastest and the only one reversible by sugammadex?
That would be rocuronium. Its speed makes it a great alternative to Sux, and the specific reversal with sugammadex makes it one of the safest and most controllable agents we have today.
This has been an incredible journey, from the spinal cord all the way down into the muscle fiber itself. We've covered the central calmers, the junctional jammers, and the direct inhibitors.
I really hope this provides that clinical framework you need to understand, not just what these drugs do, but why and when we use them.
Absolutely. Thank you for providing us with such a detailed and well-structured set of source material to work from.
Before we sign off, I want to leave you with one final provocative thought to mull over based on what we learned about Botox. We said that it works by permanently destroying the proteins needed for HE release. The paralysis lasts for months. If the damage is permanent, how does the muscle ever start working again? The answer is amazing, the body's own neuroplasticity. The nerve axon recognizes that its connection is dead, and it actually begins to sprout entirely new nerve endings, a process called axonal sprouting that grow around. Welcome back to the Deep Dive. Today we are strapping in for what is, I think, perhaps the most immediate and intense area of human physiology.
Oh, absolutely.
We're talking about the body's instantaneous survival mechanism, the fight-or-flight response, and, more importantly, how we as pharmacologists and clinicians leverage, manipulate, and sometimes hijack that system using chemistry to save lives in the most critical situations you can imagine.
This is truly where milliseconds matter. We are diving into the core of the adrenergic system. And if you can understand the chemistry of this system, you unlock the foundational pharmacology of critical care, anesthesia, emergency room medicine.
Everything.
Everything, even common treatments for things as routine as asthma or congestion. It's the ultimate master key in medicine.
Absolutely. Our source material today is a comprehensive, multi-step masterclass titled The Sympathetic Symphony, a masterclass on adrenergic agonists. Our mission is to take you from the molecular blueprint, the simple amino acids that start the whole process, and bridge that journey all the way to the complex, life-altering medicines that rely on this chemical pathway.
We're tracing the molecules, understanding the locks, and then building the keys.
Exactly. Ready to begin.
Ready to descend into the molecular kitchen.
Okay, so let's unpack this, starting at the absolute foundational beginning. We're looking at slide 2. The molecular kitchen, how catecholamines are made. If the body's going to generate this high-speed, widespread response, what are the raw ingredients? How does it assemble this chemical messenger?
So the primary molecules that orchestrate the fight-or-flight response are called catecholamines. This family includes noradrenaline, or NA, and adrenaline, which you might know as epinephrine.
Right.
They aren't created from scratch. They're synthesized through a very specific enzyme-driven assembly line that starts right inside the adrenergic neurons.
So what's the starter dough for this high-octane recipe? What's step 1?
Step 1 begins with a simple, readily available amino acid, tyrosine. Tyrosine is actively transported from the bloodstream right into the neuron. The body has to have a good supply of this basic building block to keep the sympathetic system primed and ready to go.
And the neuron needs control. It can't just be flooding the system with adrenaline all the time, so there has to be a regulator, a choke point in this assembly line.
And that brings us to step 2, which is without a doubt the most critical regulatory point. We call it the rate-limiting step.
The bottleneck.
Exactly, the bottleneck. In this step, tyrosine is converted into a substance called DuPi, or dihydroxyphenylalanine. The enzyme that does this conversion is tyrosine hydroxylase. This enzyme is incredibly important because it dictates the entire pace.
So if the body needs more, it just makes more of this enzyme.
Precisely. If the body is chronically stressed or needs a massive supply of sympathetic messengers, it upregulates tyrosine hydroxylase. It is literally the main control valve for the entire synthesis pathway.
The pace car, controlling the flow of traffic on the assembly line. That makes DOPA our first crucial product.
Exactly. And once DOPA is formed, it moves very quickly to step 3. Here, it is converted into dopamine using the enzyme DOPA decarboxylase. Now, dopamine is a crucial neurotransmitter in its own right, vital for motor control and reward pathways in the brain. But in the context of the sympathetic nervous system, it's primarily an essential intermediate, a stepping stone.
So now that we have dopamine, where does it go for the next stage of processing?
That's step 4. Dopamine is pretty reactive, so it needs to be protected and prepared. It's moved into a specialized little sac inside the neuron called the storage vesicle.
Aha, okay.
You can think of this as putting the ammunition into a protective casing, keeping it safe from any cleanup enzymes that are floating around nearby.
And the final transformation happens only once it's secured inside this protective sac.
It's exactly right. Step 5 happens inside the vesicle. Dopamine is converted into noradrenaline, NA, by the enzyme dopamine beta hydroxylase. This noradrenaline is then stored, just sitting there, ready for immediate nerve impulse-triggered release. This NA is the primary local neurotransmitter. It's released by the vast majority of sympathetic nerve endings all over your body.
That gives us noradrenaline, the primary local message sent from the nerve to the target organ. But what about adrenaline, the infamous surge, the hormone that causes that widespread alarm feeling?
That distinction rests entirely on location. It's a geographical thing. If the synthesis process continues in a special place, the adrenal medulla noradrenaline undergoes one final conversion.
And the adrenal medulla is that gland sitting right on top of the kidney.
That's the one. NA is released back into the cytoplasm of the cells in the medulla and is converted to adrenaline, epinephrine, by an enzyme called N-methyltransferase. This adrenaline is then mass-released directly into the bloodstream.
So NA is the fine-tuned, localized, sympathetic signal, like a direct message.
A direct message, yes. And adrenaline is the loud, widespread, systemic alarm signal. It's the all-hands-on-deck broadcast.
That is a phenomenal distinction. Local control versus widespread. Panic, really. So once that message, that noradrenaline, is released into the synapse, the job of the neuron isn't done. The body needs an off switch.
It does, and it needs a very fast one. We've traced the synthesis. So now coming to next slide, this is slide 3. The message is sent, then recycled. If that signal were allowed to run indefinitely, the body would remain in a state of high alarm, which is metabolically exhausting and, frankly, highly dangerous. So the body has an incredibly sophisticated cleanup crew to stop the signal quickly.
Okay, so which mechanism is the most efficient, the most important one in actually stopping that sympathetic action?
Overwhelmingly, it's one, neuronal reuptake. This single mechanism is responsible for terminating the action of 80 to 90% of the released noradrenaline. The neuron has a high-affinity transporter, sometimes called the neuronal reuptake pump, or uptake 1, and it functions like a hyper-efficient vacuum cleaner. It just sucks the Na molecules right back into the nerve ending.
So the neuron is incredibly pragmatic. It reclaims its chemical messenger for two reasons. One, to terminate the signal quickly.
Right.
And two, for efficiency, right? It's recycling the expensive building blocks it just made.
Absolutely. It saves energy, and it preserves resources for the next fight-or-flight event. It's the primary way the nervous system resets itself. But you still have 10 to 20% of that Na floating around, maybe diffusing away or lingering near the receptors.
How does the body handle the residual messenger that didn't get vacuumed back up?
That's where, too, enzymatic degradation steps in. The leftover catecholamines are rapidly broken down by two major catabolic enzymes. The first is MAO, which stands for monoamine oxidase. MAO is primarily found inside the neuron. It's ready to degrade any catecholamine that might leak out of the storage vesicles or any of the recycled Na that isn't immediately put back into storage.
And the second enzyme handles the molecules outside the nerve ending.
Correct. That's COMT, or catechol-methyltransferase. COMT is found primarily outside the neuron in the synapse, and is very abundant in the liver and kidneys, ready to metabolize any circulating catecholamines. These two enzymes, MAO and COMT, are the major metabolic players that render Na and adrenaline inactive.
And there's a third, minor one.
A very minor one, yes. 3, diffusion. A tiny amount simply drifts away to be metabolized elsewhere in the body. It's not a major player.
Okay, now let's tie this cleanup process directly back to clinical diagnosis, which the source material highlights with a great clinical pearl here. Pheochromocytoma. You're tracking a massive, uncontrolled sympathetic surge. So how does tracking the trash help you diagnose this condition?
This is a beautiful example of biochemical sleuthing. A pheochromocytoma is typically a benign tumor of the adrenal medulla that just autonomously pumps out enormous quantities of noradrenaline and adrenaline. These patients exhibit extreme, paroxysmal symptoms, sky-high blood pressure, profound sweating, headaches, a pounding heart.
And I imagine if the body's recycling and degradation mechanisms are so fast, trying to measure the actual active neurotransmitter in the blood might be misleading or just really difficult.
Precisely. It's there and gone in a flash. So instead, we track the final, stable, inactive breakdown product. When MAO and COMT finish chewing up all those excess catecholamines, the final major metabolite is something called vanillamandelic acid, or VMA.
And that's stable enough to measure.
It's very stable. So we collect the patient's urine over 24 hours, and we measure the VMA level. A significantly elevated love normal is around 4 to 8 milligrams per 24 hours, is the classic diagnostic signature for a pheochromocytoma. This really confirms that understanding degradation is just as important as understanding synthesis.
So the diagnostic marker isn't the active molecule itself, but the signature of the massive continuous destruction process. That's a wonderful example of clinical relevance.
It is.
We've made the key, we've released the key, and we've recycled the leftover material. Now we need to know what the key actually unlocks. Now coming to next slide. Slide 4. The docking stations meet the alpha and beta receptors. How does this chemical messenger translate into a biological action?
The messenger needs a receiver, a docking station. And those receivers are specialized proteins embedded in the cell surface called adrenergic receptors. When the catecholamine key fits into the receptor lock, it signals the cell to execute the fight-or-flight command.
And you mentioned earlier that this isn't a simple on-off switch. This is more like a massive amplification system.
Correct. The core concept here is that all adrenergic receptors belong to the class of G-protein coupled receptors. You'll see them called GPCRs. When the catecholamine binds, the receptor changes its shape, which in turn activates an internal G protein. This G protein then kicks off a complex internal chemical chain reaction, often involving chemicals like cyclid AMP or CAMNP or IP3.
So instead of a simple light switch, it's more like setting off a chain of dominoes inside the cell.
Exactly. Imagine one single molecule of noradrenaline hitting one receptor, but that one receptor then activates dozens of G proteins, and each of those catalyzes the production of hundreds of second messengers inside the cell. That rapid, massive signal amplification is why the sympathetic response is so instantaneous and so powerful. It allows a tiny concentration of chemical messenger to elicit an overwhelming response throughout the entire body.
That truly explains the sheer force of the adrenaline rush. So GPCRs amplify the signal. What are the main receptor families we need to map out?
We have two main families, alpha receptors, which are subdivided into alpha-2 and alpha-2, and beta receptors, subdivided into beta-1, beta-2, and beta-3. And for you, listening, we need a simple rule of thumb to keep the actions straight. This is especially helpful when we start talking about selective drugs.
Give us the memory hack for the general actions.
Okay, think of the alpha receptors as causing contraction or constriction.
Okay.
They narrow things down, they squeeze muscle, they tighten vessels.
They're like the emergency hydraulic clamps.
Precisely. Conversely, think of the beta receptors as causing relaxation or stimulation. They open things up, they dilate vessels, they relax muscles, or they speed things up, like the heart. Contraction versus relaxation stimulation. That dichotomy guides nearly all of sympathetic pharmacology.
That sets the stage beautifully. So let's now apply that rule to the specific locations in the body. Coming to next slide, we are on slide 5, location, 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 receptor functions.
This is the operational manual for the sympathetic system. Let's start with the primary constrictors, the alpha-1 receptors.
Okay, where do they exert their dominant effects?
They are heavily expressed on the smooth muscle lining, nearly all systemic blood vessels. So their activation causes intense vasoconstriction, which sharply raises blood pressure. This is the mechanism that ensures blood is directed away from non-essential areas like the skin or the digestive tract. It's why you might look pale when you get the sudden fright.
Right, the blood is being shunted away. What about other constriction actions?
Well, alpha-1 receptors also control certain muscles. In the eye, they cause the radial muscle to contract, which leads to mydriasis, or massive pupil dilation, to maximize visual intake during an emergency. They also cause the contraction of the urinary sphincter, promoting temporary urinary retention. Again, it's all part of shutting down non-essential functions.
The alpha-1 receptors are all about maximizing blood pressure and prepping the sensory systems. Now, what about the alpha-2 receptors? They have a really fascinating role as the system's own self-regulator.
They are the feedback mechanism. Alpha-2 receptors are unique in that they are often found on the presynaptic nerves themselves. So if the system is firing too heavily, the excess noradrenaline in the synapse actually loops back and hits these alpha-2 receptors.
Ah, so it tells the nerve to ease up.
It acts as the brake pedal. It signals the nerve to decrease NA release. It provides essential negative feedback to prevent an overshoot, to stop the system from running away with itself. They also help decrease insulin secretion from the pancreas, another energy conservation measure.
That internal regulator keeps the whole machine from seizing up. Okay, now for the betas. Let's start with the most critical one, the beta-autonomic receptors.
The beta-autonomic receptors are defined by their location, the heart. Activation here causes powerful cardiac stimulation. That means we see increases in everything. The rate, which is chronotropy, the force of contraction, inotropy, and the electrical conduction, dromotropy.
So faster, harder, and more efficiently.
Exactly. They also promote renin release from the kidney, which feeds into the broader system of blood pressure control.
And we lock that location in with a simple, effective mnemonic.
You have one heart-right arrow beta-1. It's the single most important location for that receptor subtype. You just can't forget that one.
Excellent. That leaves the beta-2 receptors, the great relaxers and dilators. If beta-1 speeds up the heart, beta-2 opens up all the necessary pathways for the emergency.
And the mnemonic here is equally useful. You have two LENGS right arrow beta-2s. Their primary role is relaxing smooth muscle. So in the lungs, this relaxation causes bronchodilation, opening the airways wide for maximum oxygen intake. This is absolutely crucial for respiratory drugs.
What other smooth muscles do they affect?
They cause relaxation of the smooth muscle in the uterus. This property is harnessed pharmacologically to suppress premature labor. And critically, beta-2 receptors are also found in the blood vessels that supply our skeletal muscle. Activation here causes dilation, ensuring rapid and massive blood flow to the muscles you need for fighting or running. It perfectly balances out the alpha-1 constriction happening in the non-essential areas.
And finally, a key metabolic effect to fuel the whole emergency.
Yes, beta-2 receptors in the liver stimulate glycogenolysis, that's the breakdown of stored glycogen, to immediately boost blood glucose levels. This provides instant fuel for the muscles in the brain.
And just to be complete, let's not overlook beta-3.
The beta-3 receptors are primarily involved in longer-term energy mobilization. They're located in adipose tissue or fat tissue where they stimulate lipolysis, the breakdown of fat stores for energy.
This detailed map gives us the complete blueprint. We know the chemistry, the cleanup, the receptors, and their locations. So now we can shift our focus from the body's natural process to how we build artificial keys to intervene in that process.
Now it gets interesting.
Okay, we're transitioning now into slide 6, Hacking the Synapse, a map of drug actions. Once we understood this whole lock-and-key mechanism, pharmacologists realized that every single step in the life cycle of noradrenaline was an opportunity for pharmacological intervention. Walk us through these 7 major intervention points.
This slide really details the true artistry of neuropharmacology. We can attack the sympathetic system before, during, or after the release of the messenger.
So let's start by disrupting the assembly line itself.
1. Inhibit synthesis. If we block that rate-limiting enzyme, tyrosine hydroxylase, we stop Na production cold. The drug metaricine does this. It's not a common drug, but its clinical context is pretty severe. It's used primarily to control extreme catecholamine release in patients with inoperable pheochromocytoma, essentially starving the tumor of its raw material before surgery.
But the drawback is you block the entire sympathetic response.
Which requires extreme caution. Yes.
What about targeting the protective vesicle, the storage unit?
That's 2. Disrupt storage. If you prevent dopamine or Na from getting into those storage vesicles, they're left unprotected in the neuron cytoplasm. And the ever-present MAO enzyme just quickly degrades them. The classic example here is a drug called Reserpine. Historically, it was used for hypertension, but it's such a powerful tool that it completely depletes the neurotransmitter stores.
And that would lead to major side effects.
It did. Severe depression. Because it impacts multiple neurotransmitters, not just noradrenaline.
So those drugs stop the system by destroying the ammunition before it's even armed. Now, how do we block the firing mechanism itself?
That's 3. Prevent release. These drugs physically block the nerve impulse from successfully opening the voltage-gated calcium channels that are necessary to dump the Na into the synapse. Guanethidine and beryllium are examples. They effectively muzzle the nerve ending, preventing the emergency signal from ever reaching the target cell.
Okay, now let's look at the cleanup crew again. This involves some very commonly abused and prescribed drugs.
For 4, block reuptake. This is absolutely critical. By blocking that high-affinity neuronal reuptake pump, you leave the released Na floating in the synapse for a much, much longer time. The natural signal gets intensely amplified and prolonged.
And the examples are huge.
Major drug classes like tricyclic antidepressants, TCAs, and potent drugs of abuse like cocaine. They don't add any new chemical to the synapse, they just dramatically amplify the effect of what's already there.
If blocking reuptake amplifies the signal, then the next category, 5, promote release, causes an absolute flood.
Exactly. These drugs force the nerve to dump all its stored ammunition, whether there's an electrical impulse or not. Amphetamine and tyramine are the key players here. Amphetamine literally enters the nerve terminal and pushes Na out, resulting in this powerful, non-physiological surge that just overwhelms the system.
And target 6 is the real focus of our deep dive, the external key.
That's 6. Mimic the messenger, adrenergic agonists. These are the drugs that simply act directly on the alpha and delta receptors, the locks mimicking the action of noradrenaline or adrenaline. They're designed to be selective, long-lasting, and predictable, giving us precise clinical control.
And finally, stopping the degradation itself.
7. Inhibit degradation. By blocking the MAO or COMT enzymes, you ensure that any Na that is released, or even leaks out, survives for much longer. MAO inhibitors are used to treat depression or Parkinson's, and COMT inhibitors are used in Parkinson's. But their ability to amplify sympathetic signals is exactly why they pose such a serious risk of drug interactions when they're combined with any Na-releasing or Na-mimicking agent.
That is a remarkably detailed map of pharmacological intervention. It shows that manipulating the nervous system isn't just one trick. It's 7 different ways to change the outcome.
Precisely.
Now that we know the targets, let's categorize the actual weapons we use. Now, coming to next slide. We're on slide 7, how to organize the sympathomimetic family. Now, sympathomimetics, these are drugs that mimic the sympathetic system. This family is huge. How do we categorize them logically?
We use 3 main classification systems. The first one, by chemical structure, is the most fundamental because the structure dictates the metabolism and the administration route.
Tell us about the structural difference between the 2 main groups.
We divide them into catecholamines and non-catecholamines. The catecholamines, so adrenaline, noradrenaline, dopamine, dobutamine, they all possess a specific chemical grouping called the catechol nucleus.
And what does having that nucleus mean clinically? What's the bottom line?
The bottom line is that they're extremely potent and fast-acting, which makes them ideal for emergency infusions. However, that structure also makes them highly vulnerable to metabolic attack, specifically by MAO and COMT. The clinical consequence is that they are rapidly inactivated. They have a very short half-life, which means they must be given by injection or IV infusion. They are not effective orally.
Because they get chewed up in the gut and liver before they can be absorbed.
Exactly. So if you need a drug that you can swallow, you need a non-catecholamine.
Okay.
Ephedrine, phenylephrine, and salbutamol are non-catecholamines. By lacking that catechol nucleus, they are protected from COMT breakdown. This gives them two huge advantages for outpatient care. They are longer acting, often lasting for hours instead of minutes, and they can be taken orally. This is why your nasal decongestant is a pill, but noradrenaline is an IV drip in the ICU.
That structural distinction is the key to understanding administration. Okay, next up. 2. By mechanism of action. This classifies them by how they activate the receptor.
We have 3 modes. Direct-acting drugs, like adrenaline or phenylephrine, bind directly to the receptor and activate it. They are the keys themselves. They're the mimic.
Right, the mimicry.
Then we have indirect-acting drugs, like amphetamine or tyramine. They don't touch the receptor at all. They simply cause the release of the body's natural noradrenaline messenger, relying on the body's own stores to generate the effect.
And the third category is the hybrid.
The mixed-acting drugs, like ephedrine, do both. They stimulate the receptors directly, and they cause the release of stored noradrenaline. This hybrid mechanism gives them a particularly robust and powerful overall effect.
And finally, 3. By therapeutic use. This is the practical list of their jobs. This is how we think about them in the clinic.
Exactly. This is how clinicians think. We use them as vasopressors to treat dangerously low blood pressure, as bronchodilators for respiratory issues, cardiac stimulants, CNS stimulants for attention issues, local nasal decongestants, uterine relaxants, and occasionally anorectics. This classification guides the clinical decision-making process based on the desired outcome.
That structure gives us the complete organizational framework. We've covered the chemistry and the classification. Now let's meet the masters.
Let's do it.
Okay, we are moving into the powerhouses, starting with slide 8, the master conductors. Adrenaline and noradrenaline. These 2 endogenous molecules are the defining agents in emergency medicine. So let's compare the 2 ultimate messengers.
Let's start with adrenaline, or epinephrine. It is rightly called the do-everything emergency drug. It has virtually zero selectivity. It is a potent agonist at alpha-1 alpha, beta-1, beta-2-2, and beta-3-3. It fires every single sympathetic receptor it finds.
So it's a non-selective powerhouse, a real sledgehammer. What are the key effects on the cardiovascular system?
On the heart, it is a powerful immediate stimulant. It increases rate and contractility massively. Its effects on blood pressure, however, are, well, they're complex, and they're the most fascinating feature of this drug.
Why is the blood pressure response so complex?
Because it's pushing 2 opposing forces at the same time. Adrenaline powerfully activates alpha-dollar receptors, causing vasoconstriction in many capillary beds and organs, which raises resistance.
Right.
But it simultaneously activates beta-2-2 receptors, which causes vasodilation in the critical skeletal muscle vasculature. The result is a complex, often biphasic response in blood pressure when it's injected. An initial rise, followed by a fall, depending on the dose and the relative dominance of the alpha-dollar 1 versus the beta-2-2 effects.
Now compare that to noradrenaline, or rather epinephrine, the pure pressure agent.
Noradrenaline is fundamentally different because it has negligible beta-2 action. It's potent at alpha-1, alpha-2-1, and beta-1-1, but that missing beta-2 piece changes everything.
By removing that beta-2 nasodilation, the pressure effect must just be overwhelming.
It is. The dominant effect is unopposed, potent, widespread vasoconstriction, alpha-dollar 1, which significantly raises systolic, diastolic, and mean blood pressure right across the board. Noradrenaline is the absolute gold standard for raising blood pressure in septic shock because of this near-pure pressor effect.
And that extreme pressure spike triggers a natural counter-response from the body, doesn't it? A sort of pushback.
Absolutely. When the body detects a sudden massive increase in blood pressure from this severe vasoconstriction, the carotid baroreceptors fire signals to the brainstem to slow the heart down to compensate. This is called reflex bradycardia, and it is a classic expected outcome of a high-dose noradrenaline infusion. The heart tries to pump less often to offset the massive increase in resistance.
Now we come to this classic concept, the vasomotor reversal of Dale. This is vital for anyone studying receptor theory, and it perfectly illustrates the balanced power of adrenaline. Can you walk us through this classic experiment, which is captured in the graph on the slide?
Yes, the reversal confirms that adrenaline is indeed a composite of these constricting and dilating forces. So if you inject adrenaline into a normal animal, the blood pressure goes up, but the beta-22 effects temper that rise and may even cause a slight subsequent drop. That's the biphasic response we mentioned.
But the reversal, the flip, happens when we use an antagonist first.
Right, so before you give the second dose of adrenaline, you administer an alpha blocker. This chemical key plugs up all the alpha-1 receptor locks, which prevents any vasoconstriction from happening. Now, when you inject that second dose of adrenaline, only the beta receptors, especially the dilating beta-2 receptors in the skeletal muscle, can respond.
So the alpha dose squeeze is gone, and the beta-2 relaxation is left totally unopposed.
And that powerful beta-2 vasodilation completely dominates, causing the blood pressure to fall dramatically, perhaps even lower than it was before the injection. This is the reversal. The drug that normally causes a rise in pressure now causes a drop. It's the definitive proof of the existence and opposing nature of its vasoconstricting alpha-1 and vasodilating beta components. Understanding this balance is the key to all of this.
That experiment brilliantly strips away one layer of complexity to reveal the other. We know adrenaline is complex, but its utility is singular in emergencies.
It is, without a doubt.
Let's look at the next slide then. Now coming to slide 9. Life-saving medicine, the ABCDE of adrenaline. This mnemonic captures the essential cornerstone indications for this powerful, non-selective drug.
This mnemonic is indispensable for clinical practice. It's one you just have to know.
So start with A, the absolute #1 life or death indication.
A anaphylactic shock. Adrenaline is the definitive life-saving drug for anaphylaxis. Anaphylaxis is a catastrophic systemic allergic reaction where massive amounts of inflammatory mediators, especially histamine, are released. Histamine does two things that kill: profound vasodilation, so blood pressure plummets, and intense bronchoconstriction, so the airways close.
And how is adrenaline the perfect antidote to that?
It's what we call a physiological antagonist to histamine. This means it achieves the exact opposite physiological effects, but through a totally different pathway. Simultaneously, adrenaline raises the blood pressure via alpha-1 vasoconstriction, it opens the airways via beta-2 bronchodilation, and it reduces the dangerous edema and swelling via alpha-1. Plus, beta-2 activation helps stabilize the mast cells that are releasing the mediators in the first place.
So it's fighting on all fronts at once. No other single drug can do that.
No other drug can counter all three fatal mechanisms at the same time.
Okay, moving to BB bronchial asthma.
Adrenaline is a potent, fast-acting bronchodilator because of that beta-2 effect. However, because it's non-selective, its strong beta-1 cardiac effects mean we primarily reserve it for severe, acute asthma attacks, or when more selective drugs just aren't available. Selected beta-2 drugs are usually preferred to spare the heart.
CC cardiac arrest.
Adrenaline is a cornerstone drug in all resuscitation protocols. It's given intravenously, and its powerful beta-2 stimulation helps restore electrical activity and mechanical function to a stopped or severely distressed heart.
D is the clever local use. D prolongs duration of local anesthesia.
This is a beautiful application of its alpha-1 property. When adrenaline is added to local anesthetics like lidocaine, its potent vasoconstrictor effect shrinks the blood vessels right at the injection site. This traps the anesthetic locally. It prevents the blood from washing it away too quickly.
Which means the numbness lasts longer.
It prolongs the duration of the pain relief, and it decreases the systemic toxicity of the anesthetic. It's localized chemical containment.
And finally, EE, epistaxis and capillary oozing.
Applied topically, adrenaline uses its alpha-1 vasoconstriction property as a highly effective hemostatic agent. So for minor surface bleeding, like certain nosebleeds, the constriction literally stops the small vessels from oozing.
The ABCDE mnemonic truly summarizes the versatility of the master chemical. But as we saw, non-selectivity comes with risks. We now need to talk about specialization.
We do. We need to move from the sledgehammer to the scalpel.
So we are now coming to the next slide, slide 10. Choosing the right tool for the job. Selective agonists. If adrenaline is the fire hose, selectivity allows us to use a hypodermic needle targeting one receptor to maximize the therapeutic effect while minimizing side effects.
This is the era of precision medicine. We design the key to fit only one specific lock. Let's look at the key targets.
First, targeting the heart. Beta-1 selective agonists. So when the heart is failing, we need more pump force, not necessarily more rate.
Our star player here is dobutamine. It is a potent inotropic agent designed to increase the force of contraction dramatically. And critically, because it is relatively beta-out selective, it increases contractility with much less effect on heart rate and blood pressure compared to non-selective drugs.
So more squeeze, less speed.
That's a perfect way to put it. Its primary use is in acute heart failure and cardiogenic shock, giving the weak heart a powerful, controlled mechanical boost.
Okay, next, probably the most commonly prescribed class, lungs and uterus. Beta-2 selective agonists.
This group includes drugs like salbutamol, which you might know as albuterol, terbutaline, and salmeterol. Their core action is to relax the bronchial smooth muscle in the lungs and the smooth muscle in the uterus.
And for asthma, we have our rescue inhalers and our maintenance inhalers. How do the drugs in this class fit those roles?
Salbutamol and terbutaline are typically short-acting, rapid-onset agents. They're the rescue drugs. They are the absolute cornerstone of acute asthma therapy, hitting the beta-2 receptors to open the airways quickly. Salmeterol, on the other hand, is a slow-onset, long-acting beta-2 agonist, which makes it unsuitable for an acute rescue but perfect for maintenance therapy, keeping the airways open over many hours.
And terbutaline has another job.
Terbutaline specifically is also used to leverage that uterine relaxation effect to suppress premature labor. It's what we call a tocolytic agent.
Moving on to the blood vessels, alpha-Dol and selective agonists. We use these when pressure is the only problem we need to fix.
The drugs are phenylephrine and methoxamine. They cause nearly pure, intense vasoconstriction, dramatically increasing total peripheral resistance and blood pressure. Their clinical roles are varied. They're used as potent vasopressors in surgical hypotension, as topical nasal decongestants where they shrink the swollen mucosal blood vessels.
Like in a nasal spray.
Exactly, and as mydriatics for pupil dilation during eye exam.
And finally, the unique action in the brain. Alpha-2 selective agonists. This is a counterintuitive target, as it actually lowers sympathetic activity.
It's counterintuitive until you remember the alpha-2 receptor is the brake. Drugs like clonidine and alpha-methyl-dopa stimulate alpha-2 receptors, but they do so in the brainstem. This centralized activation tells the entire sympathetic nervous system to essentially stand down. It significantly decreases the overall sympathetic outflow from the central nervous system.
So instead of blocking the receptor at the end of the line, you're just turning down the volume control at the source.
That's exactly it. They're used primarily for treating hypertension. And notably, alpha-methyl-dopa has a highly favorable safety profile for the fetus, which makes it the preferred drug for treating hypertension during pregnancy. And as a bonus, topical agents like brimonidine are also alpha-2 agonists used to treat glaucoma by decreasing fluid production in the eye.
That is a remarkable demonstration of how precise we can be when targeting specific receptor subtypes. Now let's look at the agents that manipulate the system without even hitting the receptors directly.
We must. They're a very interesting group.
Now coming to next slide, we are on slide 11, the behind-the-scenes crew. Indirect and mixed actors, and this includes the special case of dopamine. Let's start with the indirect actors.
The primary example here is the indirect acting. The NA releaser, amphetamine.
How does amphetamine physically force the release of stored NA? What's the mechanism?
It's a very aggressive mechanism. Amphetamine is taken up into the nerve terminal by the same reuptake pump that usually recycles NA. Once it's inside, it gets into the storage vesicles and physically displaces the stored noradrenaline, forcing it out into the synapse. It's like kicking out the staff and taking over the control room.
Wow.
This causes a massive, non-impulse-driven flood of NA. We leverage its CNS stimulant properties to treat conditions like narcolepsy and ADHD.
Next is the mixed acting, the jack of all trades, ephedrine.
Ephedrine is highly versatile because of its dual mechanism. It directly stimulates alpha and beta-patabra receptors, and it forces the release of stored NA. This combined action gives it a sustained and powerful sympathetic kick. Clinically, it's highly important as the drug of choice for treating hypotension caused by spinal or epidural anesthesia, where rapid, reliable restoration of vascular tone is required.
And finally, the most complex clinical agent we have discussed, dopamine, the dose-dependent chameleon. This drug's function shifts dramatically based on the concentration being delivered.
This is a cornerstone concept for anyone in critical care. Dopamine is unique because it activates not only beta-alpha receptors, but also its own specific dopaminergic receptors, D1 and D2. And the effect you get relies entirely on the precise, titratable infusion rate. This knowledge is summarized beautifully by the DBA mnemonic.
Okay, let's trace the progression. Start low.
At the low dose, that's less than 2 micrograms per kilogram per minute, dopamine primarily hits the D1 receptors. These D1 receptors are found specifically in the renal or kidney and mesenteric or gut vascular beds. Activation causes selective dilation of the renal arteries.
So it actually improves blood flow to the kidneys.
Exactly. It increases blood flow to the kidneys and boosts urine output, which is aimed at preventing or mitigating acute renal failure during shock.
Then we step up the dose just slightly.
At the medium dose, say 2 to 5 mics per kilo per minute, we start hitting the beta-1 receptors. This is the inotropic phase. Dopamine stimulates the heart, increasing contractility and cardiac output, making it very useful in cardiogenic shock where the heart itself is the failing pump.
And finally, the high-pressure stage.
At the high dose, Anything over 10 mics per kilo per minute, we overwhelm the system, and dopamine now hits the powerful alpha-2 receptors. This causes widespread, intense vasoconstriction, which dramatically raises blood pressure. At this high dose, you often lose that selective renal benefit because the generalized constriction overrides the D1 dilation.
So the decision in shock management is based entirely on which effect, renal perfusion, cardiac support, or systemic pressure, the patient needs most at that moment.
That's right.
The DBA alphabetical progression is a brilliant way to remember that dose is not just quantity, it is function for this particular molecule.
Absolutely. D for dopaminergic, B for beta, A for alpha. It's a lifesaver.
Okay, so we're moving into slide 12. Using adrenergic drugs wisely. Risks and pearls. These are incredibly potent, life-altering chemicals. They demand respect, and we have to understand their inherent dangers and interactions.
The side effects of these drugs are logical. They are simply too much of a good thing, too much fight-or-flight response.
Let's start with adrenaline overdose and contraindications.
An overdose will manifest as profound anxiety, severe tremors, overwhelming palpitations, or rapid heart rate. But the serious risks involve massive hypertension, which can potentially lead to a deadly cerebral hemorrhage or stroke, and profound, potentially fatal cardiac arrhythmias.
And we must reiterate the most dangerous contraindication linking back to the Dill reversal we talked about.
Yes. Adrenaline is contraindicated in patients with pre-existing severe hypertension, angina, or coronary artery disease. But the clinical danger zone, the one you never want to see, is a patient on a non-selective beta blocker. Giving adrenaline here guarantees a potentially fatal hypertensive crisis.
Why?
The beta blocker strips away the protective beta-2 vasodilation, leaving the alpha-1 vasoconstriction completely unopposed. The blood pressure just spikes violently. This is a life-or-death interaction that every single clinician must know.
Moving to the widely used beta-2 agonists like salbutamol, what are the common side effects that asthma patients typically experience?
The most frequently reported side effect is tremor, especially in the hands. This is because while the drug is selective for the lungs, there are also beta-2 receptors in skeletal muscle, and their activation causes a fine muscle tremor. We also frequently see mild tachycardia, or a fast heart rate, because the selectivity is never 100%, and a small amount of spillover activation hits the cardiac beta-tau receptors.
And there's a subtle electrolyte risk as well.
That's hypokalemia. Beta-2 activation stimulates the sodium-potassium AT-PACE pump, which promotes the active uptake of potassium, or K plus A, into cells. This temporarily lowers the serum potassium levels. In a critically ill patient, particularly during a severe asthma attack, this hypokalemia can increase the risk of dangerous cardiac arrhythmias. It's a risk that's often overlooked.
Let's discuss the risks associated with the alpha agonists used as nasal decongestants.
These are safe for short-term use, but prolonged topical use, using that spray bottle for weeks on end, causes a vicious cycle known as rebound congestion or rhinitis medicamentosa.
Ah, so your nose gets dependent on it.
Exactly. The blood vessels in the nasal mucosa become dependent on the drug to constrict. When the drug wears off, they rebound, swelling up worse than before. This leads to dependency and potential permanent damage, which we call atrophic rhinitis.
And the drug interaction warning for oral decongestants is a high alert situation.
Absolutely. Combining oral decongestants like pseudoephedrine, which is a mixed-acting agent that promotes NA release, with MAO inhibitors is incredibly dangerous. The MAO inhibitor prevents the destruction of NA, while the decongestant forces its release. The resulting unstoppable accumulation of catecholamines can trigger a fatal hypertensive crisis and cerebral hemorrhage. Clinicians must always counsel patients about this.
Finally, a note on the dangers of anorectics, or appetite suppressants.
Many of the older appetite suppressants were amphetamine-like and leveraged CNS stimulation and sympathetic effects. The cardiac risks associated with their use were simply too high. We have to emphasize that drugs like phenylpropanolamine and sibutramine are now banned due to these significant cardiovascular risks. Modern weight loss drugs often work via completely different, safer mechanisms like fat absorption inhibition or Listat or hormonal signaling.
Safety and selectivity are paramount when dealing with this family of drugs. Okay, let's solidify this massive amount of information.
We need to.
Now coming to next slide, we are on slide 13. Lock it in, memory hacks and mnemonics. The goal of a deep dive is to not just explain the facts, but to provide tools for quick, reliable recall.
Let's review the foundational mnemonics that tie location to function.
First, the receptor locations.
The bedrock. You have one heart right arrow, beta 1, governing rate and contractility. And you have two, L and GS right arrow, beta 2, governing bronchodilation and smooth muscle relaxation.
And the general receptor actions.
Alpha-1 causes vasoconstriction. That's the squeezing action. Beta-2 causes vasodilation relaxation, the opening action.
The versatile adrenaline's uses.
The ABCDE that guides emergency medicine. A for anaphylaxis, B for bronchoconstriction, C for cardiac arrest, D for prolonging duration of local anesthesia, and E for epistaxis and oozing.
And the critical clinical trick for dopamine.
The dopamine's dose-dependent action. As the dose increases, it hits receptors in an alphabetical but backward order. D right arrow. Low dose hits dopaminergic for the kidneys. Medium dose hits beta-1 for the heart. And high dose hits alpha-1 for pressure. If you know the dose, you know the primary physiological effect.
And we keep the core terminology simple.
Sympathomimetic just means it MIMICS, the sympathetic nervous system. It's an agonist to drug that activates a receptor.
That consolidation is vital. Let's move to our synthesis phase and ensure all the critical knowledge nuggets are locked in.
Let's do it.
And now for our last slide, slide 14. Check your understanding and key takeaways. This is our moment to reflect on the most important lessons.
We've established 4 major themes today. First, you have to remember that the life cycle of noradrenaline synthesis, release, reuptake, is the master key. All adrenergic drugs, whether they are agonists, blockers, reuptake inhibitors, or releasers, are leveraging or interfering with one of those 3 fundamental steps.
Second, receptor selectivity is the most important factor in designing a drug for safe use. Phenylephrine uses alpha-dollar to shrink nasal vessels. Salbutamol uses beta-2 to open lung airways. This targeted action is what allows these potent drugs to be used safely outside of critical care unit.
Third, never forget the unique power of adrenaline. It is the undisputed life-saving drug of choice for anaphylactic shock because it is the only agent that acts as a physiological antagonist, hitting all the necessary receptors, alpha-1 and beta-2, to reverse all the dangerous effects of histamine simultaneously.
And finally, mastering the art of critical care titration. Understanding the dose-dependent effects of dopamine, DBA, is crucial. It forces the clinician to make a highly specific choice about which receptor function is prioritized, kidney, heart, or blood pressure, based solely on the infusion rate.
Now let's test that understanding with the 3 most challenging clinical scenarios we discussed.
All right, question 1. Explain the paradoxical effect when a patient receiving a non-selective beta blocker, such as propranolol, is given adrenaline.
The answer is a catastrophic hypertensive crisis. And why? The propranolol blocks the beta-2 receptors, which prevents the necessary vasodilation that would normally balance things out. Adrenaline's powerful alpha-dollar-mediated vasoconstriction is then completely unopposed, leading to a massive uncontrolled spike in blood pressure. This scenario perfectly illustrates the danger of disrupting the body's natural receptor balance.
Question 2. What is the single most important mechanism that terminates noradrenaline's action? And name a common drug that interferes with this process.
The mechanism is neuronal reuptake, or uptake 1. It's responsible for recycling up to 90% of the released Na. And the infamous drug of abuse that blocks this mechanism is cocaine, leading to a dramatic, prolonged surge of Na and intense sympathetic overstimulation.
Question 3. Why is salbutamol preferred over a drug like isoprenaline for treating asthma in a patient with a heart condition?
The answer lies entirely in selectivity. Salbutamol is beta-2 selective, meaning it targets the lungs for bronchodilation while minimizing interaction with the cardiac beta-1 receptors. Isoprenaline is non-selective. It hits both beta-1 and beta-2 and would cause dangerously significant tachycardia and cardiac strain due to its powerful beta-1 effects. That could trigger an angina attack or an arrhythmia in a susceptible patient. Selectivity literally protects the heart.
Those 3 questions truly summarize the clinical stakes of this entire system.
They do.
We started with a simple, readily available amino acid, tyrosine, and through a complex series of enzymatic transformations and precise receptor mapping, we developed an incredibly powerful, life-saving pharmacology toolkit. This deep dive has demonstrated the unparalleled power of targeted selective action in medicine.
We've seen that the sympathetic system is nature's ultimate mechanism for instantaneous survival. Our ability to manipulate this system means we can prolong life and reverse catastrophe. But true mastery comes from understanding not just which receptor a drug hits, but understanding the entire physiological landscape, especially what happens when one action, like vasodilation, is intentionally or accidentally left unopposed.
So what does this all mean for you?
It means that every time you reach for a simple decongestant, you are engaging with the same complex chemical system that guides critical care. It means that critical thinking about receptor balance, knowing the Dale effect, knowing the risks of the beta blocker paradox, is your most reliable tool, and it's your best antidote to information overload.
A profound final thought. Thank you for diving deep with us into this sympathetic symphony. Go out there and explore the interconnectedness of physiology and medicine. We're talking about the sympathetic nervous system.
Specifically, adrenergic blockers. These are the precision tools used to manage a huge spectrum of conditions, everything from, basic high blood pressure and heart failure, all the way to some really life-threatening emergencies.
That's right. Our sources for this are all wrapped up in a really powerful 15-slide guide called The Controllers, and it lays out a strategic roadmap for mastering both alpha and beta receptor antagonists.
And our mission for you, the listener, is to go way beyond just memorizing drug names. We want to make sure you understand the why behind every clinical decision, every safety rule, and every drug choice in these materials.
It's a great way to think about it. Imagine the body's sympathetic system is like a volume dial that's just stuck on high. That fight-or-flight response is always on, putting this constant stress on the cardiovascular system.
And these blockers are the tools to turn that volume down.
Exactly. They're engineered to adjust that control, to quiet the noise without just shutting the whole system down. This is all about pharmaceutical precision.
I like that. The pursuit of precision. It feels like that's the story here, isn't it? Moving from these, crude heavy hitters to surgical snipers. So let's start by defining the battlefield itself.
Perfect. So to get the drugs, you have to first understand the communication system they're designed to hijack.
Okay, so now we're coming to the next slide. The battlefield. The adrenergic synapse.
Right. We're at the synapse, that critical junction where the nerve meets the target cell. The primary chemical messenger here is noradrenaline, or NA.
And it gets released from the nerve terminal to send that stress signal out.
Exactly. And once it's out, it needs something to talk to. The source material here points to two critical types of receptors on the other side, the postsynaptic receptors.
The ones the guide calls the go buttons.
Aptly named, I think. These are your postsynaptic alpha-1 and beta receptors. You find them on target cells, so think smooth muscle in a blood vessel or the muscle tissue in the heart.
So when noradrenaline hits these receptors, the message is simple. Go.
Action. The vessel constricts, blood pressure goes up, the heart beats faster, cardiac output increases. So you can see blocking these is the main goal for treating things like hypertension or tachycardia.
But it's not that simple because the system has this built-in self-regulation.
Yeah.
And if you block that, things get messy. The feedback break.
Correct. This is so important. That's the presynaptic alpha-2 receptor. It's located on the same nerve terminal that just released the noradrenaline.
So it's talking to itself.
It's autoinhibition. When noradrenaline floats back and hits that alpha-2 receptor, it's a signal to the nerve saying, okay, that's enough, pull back, release less NA next time. It's a crucial internal dampener.
So the whole drug strategy has to be tactical. You want to block the go buttons on the target cell,
Alpha-1 and the beta.
but you have to avoid blocking that alpha-2 feedback break on the nerve, or else you get a surge of the very thing you're trying to stop.
And that tension, that exact problem of blocking the action signal while protecting the stop signal, that's what separates the old non-selective drugs from the modern precision-targeted ones. You're always looking for something that just hits alpha-1 and leaves alpha-2 alone.
Okay, let's shift focus to the agents themselves. Now coming to the next slide. The alpha infiltrators. Their mission seems to be all about managing peripheral resistance and muscle tone.
Their core actions are really twofold. First, from a cardiovascular standpoint, blocking those alpha-1 receptors on the arteries causes immediate vasodilation.
The source material has a great analogy for this, like relaxing your grip on a garden hose.
It's perfect. You decrease peripheral vascular resistance and the pressure just drops. It makes them powerful tools for hypertension.
And the second mission is pretty unique to the alpha system, the urological side.
Oh, absolutely vital. Alpha blockers are the cornerstone of managing benign prostatic hyperplasia, or BPH.
Because they decrease resistance to urine flow.
Right. The enlarged prostate physically obstructs the urethra, but you also have this high sympathetic tone in the smooth muscle of the prostate and bladder neck, which makes it even worse. By blocking the alpha-1 receptors there, you relax that muscle, and the improvement in urine flow can be dramatic.
Now let's circle back to that really critical detail we just mentioned, the alpha-2 consequence. If you block that feedback break, you get this chaotic surge of noradrenaline. What happens then, clinically?
Well, that surge of noradrenaline is going to hit any receptor that isn't locked. Since the drug is blocking the alpha receptors, the surge primarily bombards the beta receptors.
So the beta-1 receptors in the heart.
Exactly. And that triggers reflex tachycardia, palpitations, maybe even arrhythmias. It was this one side effect that really limited the use of the older, non-selective alpha blockers.
And that explains the classification system. You start with the non-selective agents, which cause this problem.
Right. They block both alpha-1 and alpha-2.
And then the field evolves toward the selective alpha-1 agents, which are much cleaner.
Precisely. The whole strategic push has been to get away from those dual blockers.
Okay, so let's get into those original agents. Now, coming to the next slide, we have the heavy hitters, non-selective alpha blockers.
Right. These are the ones that block both alpha-1 and alpha-2. And because they're not very precise, they're really only used in very specific, high-stakes situations now.
And we have to start with phenoxybenzamine. The guide labels it the irreversible bond. And that word, irreversible, just jumps out.
It is the single most defining feature of this drug. Phenoxybenzamine binds covalently to its target receptors.
The covalent bond. So unlike most drugs that form a temporary connection,
this one is basically permanent. Once that drug molecule attaches, that receptor is functionally dead for its entire lifespan. To get a response back, the body has to physically synthesize a whole new receptor, which can take days.
the analogy in the source of throwing away the key is perfect. So what does that mean in a clinical setting, an unbreakable blockade?
It means the effect is incredibly long-lasting and sustained, which is exactly what you need for its primary, very niche use, the preoperative management of pheochromocytoma.
Right, the tumor that just dumps catastrophic amounts of adrenaline and noradrenaline into the system.
Exactly. You need an unbreakable wall to stabilize that patient's blood pressure for the 10 to 14 days before you can do surgery. The flip side is if someone overdoses, there's no antidote. You just have to support them until their body can regenerate enough new receptors.
And the trade-off, like we said, is guaranteed reflex tachycardia and palpitations because you're blocking that presynaptic alpha-2 brake.
Now contrast that with the other major non-selective player, phentolamine, which the guide calls the reversible strike.
Phentolamine, so it blocks both alpha-1 and alpha-2, but it does it competitively and reversibly. It's rapid onset, short duration, given by IDV. It's the temporary roadblock.
Its reversibility and its speed make it the perfect rapid response tool. If phenoxybenzamine is the long-term oral prep work for pheochromocytoma,
Then phentolamine is the fire extinguisher.
perfect analogy. It's for immediate hypertensive crises. Spikes during the pheo surgery, sure, but also things like clonidine withdrawal or that infamous cheese reaction you see with MAO inhibitors. Phentolamine can rapidly reverse that intense vasoconstriction.
And the guide notes it has some other actions too, blocking 5-HT receptors and causing histamine release.
Yes, and while its main job is alpha blockade, those other actions contribute to its side effects, which can be significant tachycardia and even a risk of precipitating angina or heart attack. There are others in the class, like tolizolene, but really, phenoxybenzamine and phentolamine are the key players here.
This all leads so beautifully to the evolution of the field. The pharmacologists saw the problem with the alpha-2 consequence and developed better tools. Now we're coming to the next slide. The snipers, the selective alpha-1 blockers.
These are the modern standard, and it's because they hit only the postsynaptic alpha-1 receptors. They achieve all the goals, the vasodilation, the smooth muscle relaxation, while leaving that presynaptic alpha-2 feedback brake completely untouched.
And the benefit of being so selective is
Minimal or no reflex tachycardia. This is the huge clinical advantage. It makes them so much safer and more tolerable for chronic conditions like hypertension.
let's run through the roster for everyone. We start with the prototype, prazosin.
Then you have terazosin, which lasts a bit longer, and doxazosin, which is the longest acting of the bunch, so it's great for once-a-day dosing for chronic hypertension.
And this is where the source material gives us a great mnemonic hack, the osin family.
Exactly. If you see a drug name ending in osin, like prazosin, terazosin, doxazosin, you know you're dealing with a selective alpha-1 blocker. It's a really high-yield piece of information.
But then the strategy got even more precise with the uroselective agents, tamsulosin and solidocin. What makes them different?
This is a great deep dive moment. The alpha-1 receptor isn't just one thing. It has subtypes. Alpha-1A, alpha-1b and alpha-1d.
And tamsulosin and silodosin go after one of those specifically.
They preferentially target the alpha-1a subtype, which is highly concentrated in the prostate and the bladder neck, the exact target for BPH.
So they focus all their power on the urinary system, relaxing the prostate, while mostly ignoring the alpha-1b receptors in the blood vessels.
Precisely. Which makes them the absolute go-to choice for managing BPH in a patient who has normal blood pressure. They get all the urinary relief without the unwanted side effect of making them dizzy by dropping their blood pressure.
Speaking of side effects, the first dose phenomenon is a huge clinical alert for this whole class of drugs.
It is the #1 safety concern, even with the selective ones. You get this sudden, profound loss of vasomotor tone, and it can cause severe postural hypotension. People can actually faint syncope within the first hour or so of taking the first pill.
It's a serious risk. So what's the mandatory strategy to prevent this?
It's simple. Start low, go slow, and time it right. You have to start with a very small initial dose, like 1 milligram of prazosin, and you must tell the patient to take it at bedtime.
So the period of maximum effect happens while they're already lying down.
Exactly. It minimizes the risk of them falling and getting hurt. That one simple instruction just changes the entire safety profile of the drug.
All right, let's pivot from the vessels to the primary controllers of the heart. Now coming to the next slide. The beta blockers, the guardians of the heart.
This is probably the most familiar group of cardio drugs, but the complexity comes from the fact that beta receptors are everywhere. So we have to be really clear about the different types. We mostly focus on beta-1 and beta-2.
And the mnemonics here are classics. Let's run through them.
Beta-1 receptors, you think one heart. They're mostly in the heart, and when you activate them, you increase heart rate and contractility. Critically, they're also in the kidney, where they trigger renin release. So blocking beta-1 is how you slow the heart and lower blood pressure.
And beta-2.
You think 2 lungs. These receptors are responsible for bronchodilation in the lungs and vasodilation in some blood vessels. Blocking beta-2 is where all the problems come from, bronchoconstriction, metabolic issues. And that's why precision became the driving force behind the generation's framework.
And that framework is a great way to understand the history here.
It really is. The first generation, like propranolol, were the originals. They were non-selective, hitting beta-1 and beta-2 equally.
The sledgehammers.
Pretty much. Then came the second generation, the cardio specialists like metoprolol and atenolol. They aimed for beta-1 selectivity to spare the lungs.
The scalpels.
Better. And finally, you have the third generation, the advanced guard, like carvedilol and nebivolol. These combine beta blockade with other active vasodilating properties.
Okay, let's zero in on that first generation. Now coming to the next slide, we have propranolol, the non-selective original.
Propranolol was a revolution in medicine, but it definitely came with major trade-offs because of that beta-2 blockade.
So it blocks both beta-1 and beta-2. The beta-1 effects are the ones we want, right?
Right. It decreases heart rate. That's negative chronotropy. It decreases the force of contraction, negative venotropy. And it slows conduction through the AV node negative dermotropy. The overall result is less work for the heart and lower oxygen demand, which is why it's so good for angina.
But the real story is the beta-2 blockade, the effects everywhere else. And the respiratory warning is first on the list.
This is a major, major contraindication. Blocking beta-2 receptors causes bronchoconstriction. If you give a non-selective beta blocker to a patient with asthma or severe COPD, you can trigger a life-threatening bronchospasm.
So they are absolutely contraindicated.
Absolutely. The next warning for diabetic patients is just as critical because you're hiding a life-saving warning sign.
How so?
When someone becomes hypoglycemic, especially a diabetic on insulin, their body's alarm system kicks in. You get sweating, anxiety, and most importantly, a racing heart tachycardia. That's the signal that something is seriously wrong.
And propranolol blocks that signal.
It masks the tachycardia. The patient might not realize their blood sugar is dangerously low. And to make it worse, the beta-2 blockade also inhibits glycogenolysis, so it delays the body's own ability to release stored glucose to fix the problem. It's a double jeopardy situation.
Wow. The guide also mentions a vascular effect.
Yes. By blocking the vasodilatory beta-2 action in some vessels, you leave the vasoconstrictive alpha-1 action unopposed. Over time, this can worsen symptoms for patients with peripheral vascular disease.
And finally, let's talk about its pharmacokinetics. It's highly lipid-soluble.
Extremely, which means it zips right across the blood-brain barrier. This is why it can be used for things like essential tremors or migraines, which have a central component. But it's also why it causes all those CNS side effects, fatigue, sleep disturbances, vivid dreams, even depression. It's often the beta blocker people feel the worst on.
The pursuit of precision, then, led directly to the second generation. Now, coming to our next slide, we have the cardio specialists.
The whole point of these drugs was to minimize those beta-2 liabilities by focusing on beta-1.
They were designed to be selective.
Exactly. They preferentially block the beta-1 receptors in the heart, which makes them so much safer for patients with respiratory diseases. Now, I should say, they're not perfectly selective at very high doses that selectivity can be lost, but it's a huge improvement in the safety margin.
And to remember the key players, we have another essential mnemonic, the BEAM team.
This is your high-yield list for the second-gen bisoprolol, esmolol, esbutalol, atenolol, and metoprolol. These are the workhorses of cardioselective beta blockade.
And if we compare the original propranolol with a member of this team, say atenolol, the difference in lipid solubility is a game changer.
It really is. Atenolol is defined by two things. It's beta-1 selective, and it has low lipid solubility.
So it doesn't cross into the brain very well.
Poorly. And clinically, that means a massive reduction in CNS side effects, much less fatigue, fewer sleep issues, less depression. It's a much better tolerated drug for many people. The trade-off is that because it doesn't get into the brain, it's useless for treating things like essential tremors.
And we have to give a special shout out to esmolol, the Special Forces member of the BEAM team.
Esmolol is a true chemical throttle. It's an ultra-short-acting, IV-only beta blocker with a half-life of about 10 minutes.
10 minutes, wow.
It's metabolized by enzymes right in the blood, so its effect disappears almost as soon as you stop the infusion. This makes it perfect for emergencies where you need rapid but easily reversible rate control. In the OR, in the ICU, it's invaluable.
Okay, that brings us to the cutting edge. Now coming to the next slide. The third generation, the advanced guard. These drugs seem to recognize that it's not just about slowing the heart.
Exactly. It's also about actively promoting vasodilation to reduce the load on the heart. This generation adds these really beneficial non-beta blocking properties. We can break them into two main classes based on how they do that.
The first class are the mixed alpha-beta blockers, labetalol and carvedilol.
So these drugs block beta-1 and beta-2, but they also block alpha-1 receptors. You're getting the heart-slowing benefits of beta blockade combined with the blood pressure-lowering vasodilation of alpha blockade.
Labetalol is often used IV for hypertensive emergencies because of that.
It's very powerful. But for chronic management, the real star of this group is carvedilol.
Why is carvedilol so important?
Because carvedilol is one of only 3 beta blockers, along with metoprolol and bisoprolol, that is proven to reduce mortality in chronic heart failure.
Which is so counterintuitive. Why would you want to slow down a failing heart?
The thinking has really changed on this. The answer is that chronic sympathetic overstimulation is actually toxic to the failing heart muscle. Carvedilol shields the heart from that damage, plus it has antioxidant properties, and it reduces the afterload through its alpha-1 blockade. It's a multimodal lifesaver.
Okay, and the second class of the third-gen agents gets to vasodilation a different way, nitric oxide release. The prime example here is nebilol.
This is just elegant pharmacology. Nebivolol is highly selective for beta-1, but it also stimulates the endothelium, the lining of the blood vessels, to release nitric oxide.
Which is the body's own most potent vasodilator.
Exactly. So you get the heart protection of a beta-1 blocker while also harnessing the body's natural mechanism to actively lower blood pressure. It's a very clever drug.
The guide also touches on 2 more nuanced properties. Let's start with ISA, or intrinsic sympathomimetic activity. We see that in drugs like Pindolol.
ISRs are fascinating. They're partial agonists, so they block the effect of a full agonist like noradrenaline, but they also have a little bit of a stimulating effect themselves.
So what does that mean for the patient?
It means they tend to cause less of a drop in resting heart rate and fewer issues with cold extremities. They were a strategy to reduce some of the side effects of the early beta blockers, but they're not used as much anymore.
And finally, MSA, or membrane stabilizing activity.
This is basically a local anesthetic effect. You see it at very high doses of drugs like propranolol. And while it might contribute a tiny bit to their antiarrhythmic effects at those high doses, we should be really clear. For standard use in hypertension or angina, MSA is not clinically significant. It's more of a chemical footnote.
All right, let's shift into pure clinical application. And we have to start with the highest stakes mission there is. Now coming to the next slide, managing pheochromocytoma. This is where the rules are absolute.
This is the one protocol you have to memorize. It is life or death. We've talked about the threat, this tumor pumping out insane amounts of adrenaline. The patient is in a severe hypertensive crisis.
And the protocol is the critical two-step sequence. Alpha blockade first, beta blockade second.
Step 1 is mandatory alpha blockade. You start oral phenoxybenzamine. The mission is to get control of that severe hypertension by blocking the alpha-1 receptors on the blood vessels. You have to get the patient stable for at least 10 days before they can even think about surgery.
And only once that blood pressure is under control can you move to step 2.
Only then can you add in a beta blocker, often propranolol, and its only job is to control the tachycardia and arrhythmias.
Now let's just hammer home the cardinal rule, the danger of unopposed alpha stimulation. Why is it so catastrophic to give a beta blocker first?
It's pure physiology. Remember, in your blood vessels, alpha-1 causes constriction and beta-2 causes dilation. In a pheo crisis, both are getting blasted by catecholamines.
So they're sort of balancing each other out in a chaotic way.
Exactly. Now, if you give a beta blocker first, you block the vasodilatory beta-2 receptors. That leaves the alpha-1 receptors completely unopposed to that massive surge of adrenaline.
So all you get is constriction.
Intense, uncontrolled vasoconstriction everywhere in the body. The blood pressure skyrockets to fatal levels. It's a non-negotiable protocol. Alpha before beta.
And what about for those sudden spikes that happen during the surgery?
That's where you use the reversible agent, IV phentolamine. Its rapid onset and short duration make it the perfect surgical tool to knock down a hypertensive spike quickly without committing to that irreversible bond.
Okay, let's move to more common field operations. Now coming to our next slide. Hypertension and BPH.
Right, mission 1, essential hypertension. These selective alpha-1 blockers, the OSIN family, are very effective, especially in patients where high peripheral resistance is a big part of the problem.
And they have that benefit of causing less reflex tachycardia.
Right, and a nice little bonus is they can have favorable effects on your lipid profile.
How do beta blockers fit into the hypertension picture?
They're foundational. They're used for all grades of hypertension, but they're especially preferred when a patient has another condition where a beta blocker helps.
Like what?
Well, if your patient has hypertension and angina, or hypertension and a history of a heart attack, a beta blocker is the perfect choice. You're treating the blood pressure, but you're also reducing the heart's oxygen demand and improving their post-MI survival.
Mission 2, benign prostatic hyperplasia. This is just a clean win for the alpha-1 blockers.
No question. The goal is to relax that prostatic smooth muscle. But the real clinical thinking comes in choosing which alpha-1 blocker to use.
Walk us through that selection logic.
Okay, so if your patient comes in with BPH, and they also have high blood pressure.
You can kill two birds with one stone.
Exactly. The logical choice is one of the systemic selective agents, prazosin, doxazosin, or terazosin. They'll fix the BPH, and the hypotension they cause is actually a desired therapeutic effect.
But what if the patient has BPH and is normotensive?
Yeah.
Their blood pressure is normal.
Then your goal is to get maximum urinary relief with minimal systemic side effects. So you choose one of the uroselective alpha-1A blockers, tamsulosin or silodosin.
Because they specifically target the prostate.
Right. It minimizes the risk of making them dizzy or lightheaded from dropping a blood pressure that was already perfectly fine. It's precision medicine in action.
The versatility of these drugs is pretty amazing. Let's look at the next slide. A roster of other missions.
The cardiac applications just keep going. Beta blockers are a staple for angina prophylaxis and for managing many cardiac arrhythmias, especially things like AFib, where you need to slow the rate down.
And we have to re-emphasize their use in congestive heart failure.
Yes, this is so important. For decades, we thought beta blockers were forbidden in heart failure, but the paradigm completely shifted when trials proved that a select few, carvedilol, metoprolol, and bisoprolol, actually reduce long-term mortality.
Started very cautiously, of course.
At extremely low doses and titrated up very slowly. But their benefit in shielding the heart from chronic sympathetic toxicity is now undisputed.
And moving away from the heart, we see them in ophthalmology.
Yes, topical beta blockers like timolol are essential for treating glaucoma. They block beta receptors in the eye, which reduces the production of aqueous humor, the fluid inside the eye, and that lowers the dangerous intraocular pressure.
And propranolol, because it gets into the brain so well, has its own set of unique uses.
It does. It's effective for migraine prophylaxis and for essential tremors. It's also famous as a treatment for performance anxiety. It blocks the physical symptoms like the tremor and palpitations.
We also see them used in hyperthyroidism.
This is a great use. They control the awful peripheral symptoms, the racing heart, the tremors, but propranolol has a unique extra benefit. It also inhibits the peripheral conversion of the less active T4 thyroid hormone into the more active T3.
So it provides direct hormonal benefit on top of just symptom control.
Exactly. And one last one, circling back to phentolamine, we can use it to prevent tissue necrosis.
How does that work?
Well, if a powerful alpha agonist drug like a vasopressor accidentally leaks out of the IV into the surrounding tissue, it causes intense local vasoconstriction and can kill the tissue.
So you inject phentolamine right into that area.
You do. You infiltrate the area with phentolamine, and its rapid alpha blockade quickly reverses the vasoconstriction, restores blood flow, and saves the tissue.
Okay, before we debrief, we need to cover the safety review. Coming to our next slide, the dossier. Critical adverse effects and interactions.
You have to know the risks. So for beta blocker liabilities cardiovascularly, you worry about bradycardia, heart block, and if you're not careful, actually precipitating acute heart failure.
And of course, the big respiratory risk, bronchospasm with the non-selective agents.
Always. And the metabolic warning, masking hypoglycemia in diabetics, plus the CNS effects with the lipid-soluble drugs like propranolol, the fatigue and depression.
And for the alpha blocker liabilities.
Number one is postural hypotension, that dizziness when you stand up, also nasal stuffiness. And you do have to counsel male patients about the possibility of impaired or retrograde ejaculation. It's not dangerous, but it's a significant quality of life side effect.
Let's talk about the first major red flag on this slide. Abrupt withdrawal of beta blockers. Why is this so dangerous?
Because the body adapts. When you chronically block receptors, the body compensates by making more of them. It's called upregulation. Your tissues become hypersensitive to noradrenaline.
So if you suddenly stop the drug,
your normal level of noradrenaline suddenly hits this huge hypersensitive population of receptors. You get a massive rebound angina, arrhythmias, heart attack, even sudden death. You absolutely must taper the dose slowly over several weeks.
the second critical interaction is with verapamil.
This combination can be lethal. Verapamil is a calcium channel blocker that also strongly depresses heart function and slows conduction.
So it's doing the exact same thing as the beta blocker.
The exact same thing. And the additive depressant effects can lead to severe heart block or cardiac arrest. You have to be incredibly vigilant with that combination.
And a final reminder of the alpha-1 blocker safety rule.
The first dose phenomenon. Start low, go slow, and give it at bedtime. It's just essential practice.
All right, this has been an incredibly dense deep dive. Let's debrief and solidify the key intelligence. Now coming to the next slide. Mission debrief. Key intelligence for rapid recall.
We've covered a lot of ground. It's time to lock in the most important takeaways.
We established the core mnemonics. For the alpha system, the selective alpha-1 blockers are the ozone family: prazosin, doxadosin, terazosin.
And for the beta system, the beta-1 selective blockers that spare the lungs are the BEAM team: bisoprolol, esmolol, esibutolol, atenolol, and metoprolol.
And the three core clinical rules that tie it all together. The pheochromocytoma rule is
Alpha before beta.
non-negotiable.
The BPH rule is.
Hypertensive, use a systemic OSIN. Normotensive, use tamsulosin.
And finally, the asthma-COPD rule.
Avoid non-selective beta blockers, absolutely. Use beta-1 selective agents only with caution.
If you just look at the master comparison table on this slide, the differences between the drugs really tell the story of progress. They do. You have vanoxybenzamine, the non-selective alpha blocker, defined by that irreversible bond locked into its one niche use. Then prazosin, the selective prototype that made alpha blockade mainstream.
And on the beta side, you've got propranolol, the first-gen, non-selective, high CNS burden.
Compared to atenolol, second-gen selective low-lipid solubility, so it's a much cleaner drug for systemic use.
And finally, the third-gen difference, carvedil, with its mixed alpha-beta action and proven mortality benefit in the CHF.
And nebivolol, the beta-1 selective agent with that unique nitric oxide release. If you understand this table, you really understand the entire strategic landscape.
Okay, let's put all this to the test. Now coming to the final assessment slide, we have 3 clinical case files.
Case file 1 is a classic scenario, a patient with COPD, hypertension, and angina. This requires very careful thinking.
Question 1, case file 1. A 68-year-old man with COPD, hypertension, and stable angina. Which agent is the most appropriate? Propranolol, labetalol, metoprolol, or prazosin?
The answer has to be metoprolol. And the why is crucial. The patient has COPD, which immediately rules out any non-selective beta blockers.
So propranolol and labetalol are out because they block beta-2 and could cause a bronchospasm.
Exactly. Metoprolol is beta-1 selective, so it's the safest choice to treat both his hypertension and his angina. Prazosin would help the blood pressure, but does nothing for the angina.
Okay, case file 2 is the highest stakes scenario we've discussed.
Question 2, case file 2. A 55-year-old woman with a BP of 1901/15 and a heart rate of 125 is prepping for pheochromocytoma surgery. What is the correct initial pharmacological management?
The options are IV propranolol, oral phenoxybenzamine, IV labetalol, or IV ismolol.
And the answer, which should be instinctive by now, is start oral phenoxybenzamine. The patient has a pheochromocytoma. The absolute first priority is alpha blockade to control that severe hypertension. The rule is alpha before beta.
Starting any of the other agents, which all have beta-blocking activity, would risk that fatal unopposed alpha stimulation.
Precisely. You need the irreversible, lasting alpha blockade from phenoxybenzamine to get them stable for surgery.
And our last one, case file 3, tests the nuance of uroselectivity.
Question 3, case file 3. A 72-year-old man with BPH, but his blood pressure is normal at 11/7.5. Which medication is most suitable for his urinary symptoms? Doxazocin, terazosin, tamsulosin, or phenoxybenzamine?
And the answer here is?
It has to be tamsulosin. The key is that the patient is normotensive. Doxazocin and terazosin would work for the BPH, but they're systemic alpha blockers and would likely cause unwanted hypotension.
Oh, they'd make him dizzy.
Right. Tamsulosin, the uroselective alpha-1A blocker, targets the prostate with minimal systemic impact. It's the ultimate victory of precision over brute force.
That was an incredibly thorough and rewarding deep dive into the controllers. We've really traced the evolution of these drugs from these, crude beginnings to their highly specialized roles today.
We've locked down the two core systems, alpha for vessels and BPH, beta for the heart and rate. And we've hammered home those non-negotiable safety rules, especially alpha before beta. This knowledge is just foundational.
And the journey of these drugs really shows amazing pharmacological ingenuity. The sources highlighted how these small molecular changes, like the irreversible bond of phenoxybenzamine, or the shift in lipid solubility from propranolol to atenolol, or adding nitric oxide release to nebivolol, can just fundamentally transform a drug's clinical role.
It really makes you wonder about the future of precision. I mean, if we could develop a fourth generation of beta blockers, could we get even more specific? Could we synthesize a drug that achieves a highly localized beta-1 blockade?
You mean one that only acts on the diseased tissue?
Exactly. One that selectively blocks only the beta-1 receptors that are upregulated in failing heart tissue, while completely sparing the beta-1 receptors in the kidney and all the beta-2 receptors everywhere else.
An agent that could truly isolate the therapeutic action. The guardians of the heart protecting the heart, and only the heart, with no collateral damage.
That's the next great challenge for pharmaceutical engineering, and it builds directly on everything we've just covered.
Something for you to ponder.
Mm-hmm.
Until the next deep dive.